So today, as I mentioned, we're going to talk about statistical design and planning. This is just an outline of the different topics in Module 6. I believe that Roger talked about some of these. We talked about the statistical inference, correct, last week? 6.6. You know, that's one of my favorites, but it's okay. We had, you know, we had to put it in the right place for all of you to learn. So we're going to talk about the different types of study designs, the kind of which study designs allow us to draw which types of conclusions or associations, what types of bias and error are inherent in different study designs. So each study design is going to have advantages and disadvantages and will be appropriate for certain types of research questions and not others. And then we'll talk a little bit about some survey design and measurement. I know we talked, some of you who were at Purdue, we talked a little bit about this, and before it's later in the week, I may get some of your feedback about what are some areas there you'd like to focus. And then some, I know Roger and Carmen also talked about data collection and management, but we'll talk a little bit about things like creating protocols for collecting data, training. Training, you will find, is one of the most important and places to focus in collecting data if you are collecting primary data, and one of the places that is most likely for error to occur. So training your data collectors is of ultimate importance when you're conducting a study. So we'll talk about that a little bit. So this first topic is really a research design overview. And I think that many of you here probably are familiar with some of the differences between descriptive epidemiology and analytic epidemiology. What is an example of a descriptive epidemiology study or a descriptive question? Would anyone be able to provide me an example?
Study
what?
Study the characteristic of the population.
Okay, yes. So yes, studying the characteristics of the population. So you might want to know who has some kind of disease or behavior. You might want to know where it's concentrated, which populations, when does it happen? So a lot of it's the frequency and patterns of the disease is what we're discovering in descriptive epidemiology. And then in analytic, and there are some, again, with almost everything we talk about in these 2 weeks, there's a gray area. It is not absolute. So there are some ways we can, that these two may blend together. But in analytic epidemiology, we look for determinants or those factors. You mentioned factors contributing to diabetes mellitus, factors that influence prevention, occurrence, control, or outcome of disease. So what's an example of a factor influencing a disease outcome? Your choice, anyone. What's something you've looked at in your own work? What?
Monday morning.
I know it's Monday morning. It's okay. It's okay. All right. Well, let's say with diabetes, can you give me an example of any factor that contributes to diabetes or that's associated with increased diabetes? Genetics.
Just food,
Okay.
beers.
All right, yes, so some genetics, some obesity, I think I heard. So some of these are factors that might be determinants that will influence whether or not a person has diabetes. But the steps in doing this is we always first have to do the description. Describe the population, describe the people who are at risk by that time, place, and person. Now, sometimes you may be the person who is investigating the descriptive, describing the characteristics of the population. And sometimes we have national surveys or other kinds of surveillance studies that can give us that information. But we have to know, we have to describe who's affected. Then we have to have a hypothesis about what we want to see. Do we, are we hypothesizing a relationship between a determinant and an outcome? Are we hypothesizing that a certain group of people are more affected? And then test that with a rigorous study design and apply those findings to policy and action. So this is kind of condensed in a nutshell what epidemiology is, what epidemiologic reasoning is. I think we've talked a bit about, yes, the who, what, where, when. These are all describing when and where you're going to see the condition, and then how and why. Why did it arise? And so what? This is a big one too. Does this, the question, so what? Does that make sense? Like, who cares? So what? Why do we care about what we're investigating? What impact will it have on public health? Why should we care about the condition? Why do we care about diabetes? What's the effect of diabetes on the population? Anyone? Like, what might be a reason we care?
วิวัฒนาในการค้นคว้าเรื่องเบาหวานกับเป็นยังก็จึงเป็นแข่งเรื่องเบาหวาน
Economic impact. Nice.
Life.
Life. Okay, yes. Life, effect on mortality.
And genetic as well.
Genetics.
Yeah, because if number of diabetes patient increase, it means that their children, their son, their daughter will have the risk.
So for diabetes, for type 1 diabetes, yes. And I just don't know if that's the case for type 2, but it's definitely, it is for type 1, correct, Naluba? I don't know about type 2. Yeah.
Because if I have diabetes doesn't mean it's in my genes and goes to my children. Yes, because unless it's a if they have a parent or if the father who have diabetes, if you age 13, you have to go to check up for there are some risks.
That's interesting. I'm not sure.
But it's not a genetic.
Yeah, I was gonna say that might be more environmental. Yeah.
There's a family story, but that's more the family story. It's not the genetic benefit is more related to the Taiwan.
Okay.
There are some mutation gene in the diabetes. Yeah, I'm going to check more because I do research review and I said there are two factors that can change and cannot change.
Right, factors you can change and you can't change. Yeah.
Factor that cannot change is maybe age, genetic or the man, you have all this and factor that can change is for example, dietary intake or alcohol consumption or tobacco consumption.
Yes, so there's that's a great example of how, there's factors you can change, like dietary intake and alcohol consumption. There's factors you can't change, like your genetic makeup and your the gender at birth and how that contributes, or forgot what else you said. There was another age. Did you have a?
Yeah, just want to share a little bit because sometimes people misconcept or misunderstand about the type 1, type 2 diabetes regarding to the modifiable and unmodifiable factors.
Right. Yes.
Of course, juvenile diabetes or the type 1 was genetic for sure.
Yes.
That's included, and type 2 mainly about the consumption behavior and about the physical
Yes.
activities and so on. So, and in some study, there might be some correlation or some association between the family history of diabetes and type 2 diabetes occurring, something like that. But it doesn't mean that that's the cause.
Yeah.
A kind of a association for some information.
Yeah.
So,
Yeah. More of the family.
Yeah, some people might
Yes.
might make a very too fast conclusion that family history might cause to the occurrence of the diabetes, something like
Yeah.
in type 2, but it isn't. Yeah, as mean it might be statistical significance, but in some studies, not every study, and it possibly might be something else.
Yes. Yeah. So good point. The type 1 diabetes is genetic, and there aren't as many. I don't know about the modifiable. I don't know if there's any modifiable risk factors for type 1. But there may be.
Right.
But for type 2, yes, everything should be modifiable. And like you said, the family history may be contributing because of it would be likely because of the environment, because of the behaviors of the family that are affecting. Now, it is possible. There are some conditions where it's possible there could be mutations that are then passed on, but I would think that with diabetes too, many people are being diagnosed with that later in life. It will probably be after they had children also. I haven't seen any evidence of that in diabetes, but you can always look and see if there's anything in this. Yeah, right. Okay, so, but we brought up reasons to care, and that was economic impact and life, the length of life. What else were we talking about? Some other, go ahead.
I said about so what and public health impact. You said about the economy, you said about lifestyle. Because NCD now going up, and we should know. Just we do not know about prevalent on, but we know about the impact. And
yes,
it can preventable, not happen for the short time, but the long time.
Yes,
I think if we know about the prevalence of diabetes, we should know about which happen in the future, and we can prevent it.
Right. So measuring, then we can track it in the future. We can also help make some determinations of how it's going to affect the public health impact. And in the United States, diabetes it's expensive. It's expensive to treat. It costs a lot to our healthcare system, but it also has economic impact in people's ability to work. There are a lot of kind of side effects or consequences, like having feet amputated, losing your eyesight. Those all also affect someone's ability to work or to take care of others. It has a huge impact on society. So there are many reasons that we can find public health impact, but we have to make sure that we are tying our questions to this public health impact, because doing research just for the sake of research is not a good use of resources, and it's also of questionable ethics, because you don't want to enroll people in a study and take their time and have an impact on them for information or data that aren't going to have an impact or that have already been done. So that's a consideration to think about as well. Okay, so the what? I think we've done a good job of covering a lot of this, that, you know, the disease, condition, or any health-related event. So that's the what you're trying to think of as the how to characterize cases. Case definitions can be really important. If you say you want to measure COVID-19, what is your case definition of a case of COVID-19? Thoughts? How might you define a case of COVID-19?
Well, they have a symptom and diagnosis with RCT or health.
Okay, so symptoms, we could compare their symptoms against a checklist of symptoms we know are from COVID-19, the diagnostic test, as you mentioned. Which kinds of tests are there? So we have PCR and rapid test. Okay. What will the differences be in defining a case as someone whose symptoms match versus someone who's tested positive on a PCR? Which of those two case definitions will find more people with under your definition of COVID-19?
Maybe if our symptom, maybe there are many people that have the symptom, but not all of them have the positive for the rapid test.
Yes, okay, so maybe if you're defining it by symptoms, you may have more people in your group of those you define as having a case than if you only included those who have a PCR test. But what are some of the differences between who gets a PCR test and who doesn't?
Before the rapid test, but PCR it takes a long time. But the rapid test is easy and make sure to know about the result. But it doesn't matter. Some people is minus, some people are possible.
Yes, so the rapid test you'll know more quickly. Rapid test is going to be in between symptoms, PCR, rapid test.
Yes.
The PCR will take longer. Does PCR test detect active COVID-19, or can it detect if you had COVID-19 a while ago? Do you know? It's okay.
PCR is virtual.
So PCR test can say when you have active, but it can also stay positive for weeks after you don't really have symptoms. A rapid test, depending on when you take it, may or may not test positive, even if you, when I finally got COVID in May, for the first time, May 2023, I avoided it for several years. I felt bad. I took a test that day and it was negative. And then I waited 2 days and took a test and then it was positive. I mean, you can't use one rapid test really as a diagnosis. But say it's early in the pandemic when we didn't have all of the testing necessarily and people had symptoms. what were we using to tell people to maybe stay home? I don't know exactly how it was working in Laos, but in the United States, it may have been, well, if you have these symptoms, stay home, right? So my point is just that depending on how you define a case, it might be really important if you're trying to understand long COVID, people who have symptoms of long COVID, to just understand who had symptoms in a particular period of time that match along with some of the characteristics of long COVID. If you only include people who tested positive, you may miss some people with long COVID. So there are different ways to define your case, but each time you do it, it has to be clear, specific, and measurable, and relevant to your research question and your hypothesis. Any of those definitions of having COVID-19 or a case of COVID-19 are valid in different types of research. Does that make sense? Okay. So you have to be thoughtful about your case definition. This is, I take forever to talk about things. So, okay. Our descriptive epidemiology, we've talked about this again. This is our when, where, who. It's just the occurrence of these health events by time, place, and person. And again, some of the causes and factors that can go into analytic epidemiology. I'm not going to spend too much time on that because I think you understand. But the reason that study design is important is it's our blueprint or our roadmap to understanding and changing these distributions and determinants of health outcomes. You've got to have your study design. And in a long-term research plan, you may have multiple study designs that you foresee into the future in order to really understand and progress through these steps of epidemiologic reasoning. So how do we decide which one to use? It depends on your hypothesis or research question, where you are in the research, and where the research is nationally or in your area of interest. What's already been done? Again, if you already have descriptive epidemiology about your population of interest, it's not a good idea to go back to that exact same population and collect the same data, unless it's very old. You know, like there are some considerations, but you have to be, you have to take into account the ethics of conducting research that's already been conducted in the same population. We're supposed to repeat research, right, for replicability, but there's a balance. Balancing validity and quality of evidence with efficiency, that's true, yes. So what are the resources that you have? How can you do a randomized control trial with what resources you have? Sometimes you have to figure out, well, I'm going to maybe need to do it this way. And that might be slightly less rigorous in internal validity, but this is what I can do. And that's really important. It's important to realize that sometimes you can only do the study that you can do with what you have versus the ideal study. And then, yes, practical and ethical considerations.
So sorry,
Yes.
Would you explain a little bit about this stage of the research topic?
Yes, I'm going to talk about that right now. Yes. Great question. So, what is your goal? What is your goal of your research topic or your research question? So it might be kind of hard for you all to see, huh? But if you do you need, not just, but do you need to understand the patterns? Do you need to know who has the outcome, where it is, when it occurs? What do we already know about the topic? So, for example, if you don't have some of those fundamental pieces of information, I don't know who gets this. I'm not sure where this outcome is happening. I need to find out. Then that is describing the patterns, and I'll show you as we move through these slides. Then that would mean you choose a descriptive study. If that's what you need to know, you need to describe who has this. You're not even sure yet. Or do you want to estimate the risk or probability of acquiring a disease? You already know something about who has it, where they have it, but what you don't know is what people's risk is for acquiring the disease. So that might be the next. You have to already know the descriptives to move into estimating risk.
The association.
What's that?
The association.
Yes. You can, well, estimating risk, actually. So you can look at an association in a descriptive study. We'll talk about that with cross-sectional studies. But it's a little different than when you want to move to estimating risk. Do you want to develop hypotheses about the potential relationships of risk factors with disease? So you may use a prevalence study to kind of look at what people's risks are, but if you really want to look at those associations and relationships, you want to develop hypotheses, or do you want to test hypotheses? What do you think you might use just to develop some hypotheses?
When you suspect something might increase the risk of having a problem.
Well, yeah, you have a suspicion, but you don't have the hypothesis yet. You're not sure. Okay, go ahead.
Maybe based on literature review or the previous study.
Okay, literature. Yes, great. So you may be able to develop hypotheses based on literature review and previous studies. So there's probably been studies that others did on descriptives or on some of these prevalence studies. You may also, we'll talk about, and we're going to talk about this in the next slides and in today and tomorrow, but a cross-sectional study can help you to look at some associations that you can then use to develop hypotheses that you may test in, say, a cohort or a case control study. I love cross-sectional studies. I personally, DeLupa's like, because a lot of the work I do is descriptive because I measure things that other people haven't measured. So I'm still contributing a lot to what do we even know about these types of social relations and how they're related to these outcomes. So I like doing, but I do primary data collection, I develop and create surveys, and I collect the data, and I look at associations. But I'm not going to say having, 4 other women in your network of people you talk to about health problems leads to you having a primary care doctor. So I'm not going to make a leap to saying there's any kind of causality, but it starts to describe, in people who have cancer, who don't have a strong support network around them to help them cook food and take their kids to school and cover their shifts at work, that's associated with poor cancer outcomes, cancer treatment outcomes. I'm not going to say it causes it, but I can say it's associated. If I really wanted to know something more about the direction, I could do potentially a cohort or a case control, or I'd have to have this big, huge, multi-decade cohort studies so that I could know about people's social relations before they ever even got sick with cancer and then through it, right? And some of those kind of exist, but there are ways of placing your research within these areas, these stages, and some people might progress through them. And some of you, if you find yourself, I'm more of a methodologist in part. And like I said, like I investigate things that it's data that haven't been collected before. So having a lot of descriptive and associations is okay because there's still so much lacking in the literature. So anyway, okay, then testing interventions or treatments. So what might we use to test which interventions or treatments are effective? What kind of study design might we use for that? Okay. We would likely use a randomized control trial. I'm going to move through I'm going to come back to this at the end of tomorrow. And then I think that we'll all be ready to give more, that this will make more sense and we can walk through, you hang on to your research questions that you've written down and we can walk through some of these. So the stage of the research topic really is just understanding what your goal is. Where are you in this continuum of research? This is just a layout of types of study designs that can be useful when you're trying to know, okay, is this a descriptive or an analytical design? And then it's broken down into the type of descriptives, type of observational, cross-sectional, I put both. It's descriptive and observational. It can be both. So a prevalence study you might look at as more of an observational study, other types of cross-sectional that are measuring your, what you might see as factors and outcomes at the same time, maybe are more descriptive. So there's a little wiggle room here with the cross-sectional design. Case control and cohort studies are observational, and then randomized control trials and quasi-experiments are experimental, and those fall under the analytical. So you can always keep coming back to this, and I'll have questions. I don't know if it's on the next slide or not. Nope. But questions you can ask yourself to walk through to which study design you may be interested in, or if you're reading a paper and you're like, what kind of study design is this? So summarizing, descriptive studies discover patterns and associations. You usually don't have an a priori hypothesis. So what does that mean? What does an a priori hypothesis mean? Does anyone know?
Maybe we have a lot of lists or a lot of things to test, but we should prioritize the important thing with the hypothesis.
Okay, so like prioritizing a hypothesis. So this may be like a term that you haven't seen much before, but a priori just means before. So you don't have a specific hypothesis that you are going into the study with. You might have some ideas, but you're not trying to understand a specific hypothesis. You really just want to describe. So that's usually when you see this term, a priori hypothesis, that just means you have a hypothesis before you do your study. Descriptive studies are super important for planning, trend analysis, surveillance to generate hypotheses. So that's the beauty of a descriptive study. You go in without a hypothesis, then you can look at some of the characteristics and the associations that you're seeing and think, this is interesting. Maybe I should further investigate this relationship, this association, and use a more rigorous study design to understand that relationship. Yes, of course, you have to be careful with correlation not equaling causation. I think we'll have a fun conversation later. Nilupa and I were talking last night. I was saying, I'm going to show you when we talk about RCTs, a randomized intervention trial that I was a part of. And even though we had randomized people to their intervention treatments, nowhere in the final paper does it say that the intervention caused the outcome, because there are too many other factors to consider. I personally, okay, actually there is one example, and I will also show this to you in the I've done one randomized control trial. It was so much fun, where I could probably conclude which of the interventions was best. But typically, don't actually say this caused this. In my opinion, that's usually reserved for a very specific, highly controlled experimental conditions. And if it's a very highly controlled laboratory experiment, what does that mean about the results? When you have very, very high internal validity, which is the control of the components of your study, right? The conditions. What does that mean about how well you can generalize that to other populations or other people? Often there's a trade-off. The more internally valid your study is, the less you're able to generalize it or have external validity. Right? We talked about that a little bit, I think, on Friday, where we were talking about clinical trials and saying, well, they're very internally, they can be very internally valid, a phase 1. As you move through these phases of clinical trials and then out into the population, the internal validity of the study decreases, but the external validity or the generalizability, your ability to say, this is how this is going to work in a broader population, increases. So sometimes you don't want this tightly controlled lab experiment because you want something to work in as broad the population as you can. And so you say, we're going to test it in a sample of people who represent this population, and we're going to do the best we can, and we're going to show you what the results were. And we think that you can then use this intervention in populations, but we're not sure how it's going to work with everyone. Yep. Right? And that's okay. That's also good science. You have to be transparent in saying that's what you're doing. Right?
So you're saying we shouldn't be too proud if we have control everything in a experiment. Right. Unless we see it works in a broader population.
Yeah, I mean, you should be proud. Yes, you should be proud. If you have created a highly controlled experiment, you should be proud of yourself because it's hard to do. But you have to say that we know this cause and effect or this factor or predictor and outcome, however you're describing it, work in this tiny population with this set of restrictions. But we don't know how that's going to work.
In broader.
Yes.
I was just reflecting, such a nice point, because in nutrition, I think this is very common. Like in nutrition, we want to know like the effect of some kind of food or something. We do these RCTs where we give the food. Like we will go and give an egg to a family and say, give this to a baby once per day. And then in this family, we don't give anything, but we just give nutrition from something, some control treatment. And here you're giving egg. But then, and then you see, here's the benefit of egg, it increases choline and all these outcomes, all these biomarkers. But in real life, once you promoted this at a larger scale, how do families get eggs? Do they have money? Do they have chickens? Do they have whatever, right? And so it's such a difference between doing a very clinical trial. But we do that all the time. We give LNS, like lipid supplements, we give micronutrient powders, we give, pumpkin nut or what, like all of these things are very, highly controlled, very efficacious, but then just this generalizability can be a problem.
Yes.
Effectiveness in the real world.
Yeah. And then you say, so what?
Yeah.
Like, so what? If giving people this in this situation increases this nutrient profile, but you don't have a way of incorporating that into everyone's lives, why did you even do it? And I know, like, so I don't specifically do nutrition research. It seems crazy to me. Like, it seems so messy. So messy. It's because there's so much context and environment that goes into, and what people eat is emotional. It's familial. It's social. What they can access has so much to do with economics and politics, and to measure what a person eats and expect an outcome, that's hard. You all are doing hard work. You really are. And I want to like really reiterate how important it is, especially all over the world. We have poor nutrition in different ways, right? And it's so important to be looking for ways to improve and change this. But I just do want to acknowledge that you're doing some of the hardest, I think you're doing some of the hardest research. It's tough. But I think keeping in mind too, those real world situations and outcomes, when you think about and design your studies, will help you tremendously. Because, yes, it just doesn't matter if you do a tightly controlled lab experiment, but there is no way to reliably deliver this to a population. At the same time, I have a term called the no-duh research, which I don't know if you know this phrase in English. When somebody will say something, kids will do this to each other. It's very mean. I don't let my kids do it. But someone will say something, and if the other person was like, well, yeah, I knew that, they'll be like, no, duh. It's a term of saying like, it's obvious. That's so obvious. There's a lot of research that is no duh research, but it has to be done because people won't change policies without seeing the data. People may not change a system without you measuring the things that need to be changed, right? So even though it may seem like, so there's a balance, right? Why do this lab experiment if you're not able to carry it out into the world? But also, you may need the lab experiment to prove to the powers that they need to help you get it to the real world, right? It's so complicated.
And I would like to ask how strong evidence that we can feel with policymakers to create the policy for us.
That's a really good question. I don't know, that's a great question. Maybe it's very compelling, you have this huge effect size and, you had a good experiment, but maybe you had a really good real world experiment. You tried something in some schools and you really saw patterns change. I think that that's a really good question. And I think that that's up for debate and that people will use different criteria. I've been helping to edit policy briefs on another project I work on based on, one study that we did, but it's not there was no kind of inference of cause and effect, but it was saying, here's what we measured in here, here's what we found. And we really feel like we heard from people and they said that this was a barrier to us being able to, it was about using wild plants in food and medicine and traditions in northern Iraq. And we found that people working with these groups weren't helping to prioritize this cultural tradition and conservation of these plants, right? So it's okay to write a policy brief for the policymakers in this small government and say, hey, it's important you're overlooking these needs of your people, and we think you could take these steps to change that. So I think that's okay. It really depends, I think, on the research and the policies you're trying to change and the policymakers. I have no idea if that policy brief will be effective. No clue. I'm interested. We'll see. Yes, it's very complicated. Very complicated. We were also just talking last night that hearing my kind of nihilistic views of, it's like, I don't think the food systems in the United States will ever change. There's too much money involved. And, so, but keep trying. So I'm happy that Nalupa will keep trying. And I'll keep trying other things. But yeah, it's really complicated and really complex. And I just want you all to know how important all of the work you're doing is, and now no one's going to get it perfect. And, helping each other too is so important. And just creating this evidence and making the compelling arguments. We're like, so what are we? It's 10. What time am I supposed to be done? Or do we have a break? Oh, 10:45 is the break. Was I supposed to get through both slideshows by 10:45? Yeah, I'm terrible at this. This is why I had to, recording all of these was, they were a bit longer than I know it was initially, but I was like, I can't talk about this in 15 minutes. But, yeah, tangents. Big fan of tangents. Okay, so in analytic studies, one of the key components to having an analytic study is a comparison group. Comparison group and follow-up. That's what you need to identify this association or relationship. We do this for causal inference, targeting prevention and treatment, hypothesis testing. So again, you can't prove an exposure caused a disease, but you may be able to provide some temporality or stronger evidence of an association. But you can both, yes, you use it to identify characteristics associated with the disease and for testing. So descriptive to generate hypotheses, analytic for testing hypotheses. Okay? That's one thing to keep in mind. Oh, here, we have some questions. Do you know the distribution and patterns of disease? This can help you think about which study design you want to use. So if you know the distribution and patterns of the disease, yes, then you may move right into analytical. If no, you can move into, oh, but you already have a comparison group, you could also go into analytical, or you can move into descriptive. Do you have a hypothesis? Are you ready to test an association? So if you can answer, let me see if this is the pointer. Oh, nope, never mind. If you can answer these questions about the distribution and patterns, and if you have a hypothesis, thank you, and you're ready to test, thank you, associations, then you can move into an analytical study. And these are what we're going to talk about more over the next couple days. Balancing validity and quality of evidence with efficiency. So, well, let's see what we're going to talk about here. This depends on your type of study design, execution, and generalizability. So this is a little bit about what we were just talking about. So your internally valid, your high internal validity, lab-based, very restricted conditions study versus your real-world based, maybe practice, based kinds of studies. You have to balance which is going to work for you, and it depends on study design, how you execute it, and the generalizability. Your internal validity says, can we believe the study results? The ideal of internal validity is an absence of bias. It's rare. Yeah, I know. I see your face. I don't know that ever happens, but it's that's sort of the goal, the lofty goal. And external validity are the results applicable to other populations? So sometimes you have to balance those. Like I was just saying, you might have an intervention trial where you can mostly believe your results, but certainly there could be other factors that you weren't able to measure that affected the relationship. What's that called? Louder. Yes, confounders, right? Could be a confounder that you weren't able to measure. Because in the real world, you can't measure all of the confounders, right? But it's generalizable because you did it in this very, a bigger representative sample. So is that what you want or need for your research question? Or do you need that strict lab, restrictive, internally valid space? All right. So basically, yes. I think, have we made this point today? There's a trade-off between these two types of validity. That is what I want you all to keep in mind. Okay. This is where study designs fit on your kind of increasing strength of evidence, and you have your descriptive study designs and your analytic study designs. And this is also just these are kind of references, ranking, highest validity to lowest validity, like a case study. Some of you who are physicians might do case studies sometimes. They're very important, but they're there may be one person or a handful of people. And this is just to kind of lay it across some of these this study design tree that has kind of the lowest internal validity to the highest internal validity, right? In general. But when you're balancing validity and quality with efficiency and practicality, you'll see that these analytic studies with comparison groups, this is hard to read, but it says higher cost and least practical, resource intensive, right? So doing a randomized control trial or experiment, or even, anything with follow-up, but these kinds of study designs take a lot more money, a lot more time, a lot more people to do. So they're much harder to do. then these kinds of study designs that are very feasible, they're usually lower cost. Right? Okay. Oh, I pressed the wrong button again. There we go. Okay. So I'm going to let you, so how would you do this? Oh, measuring association between dietary intake and body composition. So what is one way, how would you do this in a descriptive surveillance study or a survey? Measuring associations between dietary intake and body composition. What's a way to do this in a descriptive study? I think some of you in here have done descriptive studies of
Something.
yeah, does anybody have a study where they've measured dietary intake and body composition?
We can have it.
So you did?
Similar. So the body composition is weight and height.
Weight and height? Mhm.
BMI. What?
Okay. And what was the dietary intake?
1 hour a day, 24 hours.
A 24-hour, if you recall?
Proficiency questionnaire.
Mhm. And so would you do that? Would you measure their, when would you measure the food intake and when would you measure the height and weight? In a descriptive study.
Okay, go to interview.
Yeah, all at the same time.
Yes, oh.
Right? Yes. Yes. So in one example of a descriptive study of dietary intake and body composition, you may go somewhere and you measure, you may be in the school or in a community place, dietary intake using one of the measures that Kevin even mentioned, or and height and weight all at once. Great. What kind of study is that? What is it? It is descriptive. And what kind of, well, we probably need a little more information, but which kind of these is it, of these study designs? Yeah, probably cross-sectional. There's some nuance between this is more when you're doing this at like a kind of a population level. So I would say, yeah, it's a cross-sectional study, right? Okay. How much, did it cost a lot of money? Was it easy or hard to do? Sort of easy, sort of hard. It's time intensive, right? But is it more or less time intensive than the whole population, or selecting and randomizing people? So just kind of thinking through how easy or hard some of these are to do, what you need to do them. And then what's the quality of your evidence? If you find associations there, what's the quality of your evidence in looking at associations in a cross-sectional study?
We just know about associate, but we didn't know about cause and which cause really outcome or determine what happened before, but we just know about relationship.
Exactly. So there's no temporality. We don't know which, as we say, the chicken or the egg, which came first. But you're measuring it at once, and you can say, okay, well, among people with this body composition, we saw this dietary intake, or among people with this dietary intake, we saw this body composition. But you don't know, and it's not that it's poor evidence in any way. This is understanding who your population is, what what is the prevalence of their, the body composition and dietary intake in that group. And then you can move on to something next. If you want to have test a hypothesis or look further, right? But this is important. It's still important, and it's still quality work. There's just you're not saying that one thing caused another, right? Yeah.
Can you explain exactly why you couldn't tell cause and effect? Yes, like we about observational study, we just interview or did the research on observational study, but we didn't know about dietary intake, effect. Which one is the first dominant or exposure? We say about exposure on that, but when we did the cross-sectional, we know about this time, not the before.
We can conduct only the period that we have just some time that.
Maybe they ate better before, but now they eat better. And that's a change. Temporarily.
Yes. Yeah. Okay. Let's go. So this would be, let's just quickly talk about how you might do this in a lab study or experiment. How would you measure an association between dietary intake and body composition in a lab experiment? What might you be able to do differently than, say, going into a community and taking measurements? If you had a lab. Go ahead, louder. Okay, but before we even want to provide it, and well, okay, we can control the intake and output, right?
Yes.
Okay, so how might we do that?
Identify the group we would like to intervention. Maybe we have before and after, or we have to.
Yeah, so two groups eating different things, or measuring somebody eating before and after eating something. This is kind of, Nulupa, what was the example you gave?
If they ate before. Oh, the egg yolk?
Oh, right, yes, yeah, was that it? With like a lab experiment of
whether people are providing eggs versus like, is it that one?
yeah, I think so. You said something about
Or supplements.
Yes.
Yeah.
Yes.
Or fortified foods, fortified foods, where you do specific meal.
Right.
And that's common where you ask people to come to you and you feed them and you watch them and then you send them home. So you know they need it. That's
right.
Common studies.
Yeah.
What would it take something else when they got home? You have checklists for them to report it.
Sometimes if you do a good study, you want to do that. You'd also ask what you eat at home.
Yeah.
Maybe daily report.
I have question about this because I also thinking about that long time ago. But some people said that maybe this will be different anyway because someone had this amount and someone had also amount, but additional something that have energy and carry. So is people anyway even not big, but energy is small for this group and for the
So we can go into lots of details. So yes, it would be like a randomized trial, right?
Yeah.
And if you did it well, you would balance calories. that doesn't always happen. If you give an egg and you give something else that is similar.
Same calorie.
Yeah, but a different nutrient profile. That would be one thing to make it better. Or you give something where it's like, yes, someone goes home and they eat something. Or what's more common is if you give a good food, then at home they don't worry about eating more. My baby got an egg, I don't eat milk,
yeah,
you know, something like that. You have to measure all the things
yeah,
to build a strong piece of evidence to attribute it to an egg.
yeah. And so, and that's the hard thing. So with these experiments, you're controlling the environment, and you're unlikely to control the environment in the real world. Or you use the data you get from these to say, here's how we need to change the environment in the real world to make this possible. Right? Okay. I'm gonna, so we will talk about this with each of the study designs. We'll just keep this, you can look at this as a reference. I know you've seen this. Characteristics, strengths, and weaknesses of different study designs, as kind of a shortcut to say like, okay, this is something I can calculate the prevalence in this one, but not this one. But I won't harp on that. We'll do I know we don't have, you just want to stand up and do a little stretch. How about, wait, I was trying to find, I know we don't have the, establishing your analytic methods and plan, choosing the right measures of disease frequency or analyses, or association, and then controlling for bias in planning and analysis. Where is the best place to control for bias? Planning or analysis?
Hello, Sabaidi, and welcome to Top.
Oh no, that's my voice. It's terrible. You think?
Is the first thing that we should do are to minimize the environment as we can. That's that from planning.
Yes.
Then after that, we will do anything with the data collections on staging. Yes, maybe go to the state of the statistical.
Yes. Yes, thank you. So it's best, you have to start planning for bias in the planning of your study and your study design. And then you can control some of the bias in your analyses. But the best approach is to really think about it in your planning. So we talked about this. There are just some examples of descriptive epidemiology or descriptive studies distribution. So looking at population descriptives, I think this is a report on stunting in the MIX 2017 data, and two different ways. So this one is showing, it's kind of hard to see, but this is the underweight. I can't read what that says. Can anyone, I'm sorry. Wasting, thank you. Overweight
And stunting.
and stunting. So for the different colors. So this is a really nice visual descriptive of the prevalence of each of these in this population. And it's by age. And then here is a range of the same percentage of under 5 children who are stunted by background characteristics. So this tells you this is by area, rural or urban.
Flores and riches.
What is it?
And top one is Flores.
Oh, poorest and richest. Okay, wealth quintile, I think. Maternal education. And you won't see this. Okay, ethnicity and province. Sorry, it's just hard to see on this, but if you have your own. This is also another nice indicator of showing it's the percentage of children under 5 by the province, by the ethnicity, and just showing the characteristics of your population in these distributions. This is another way. This is common that we'll see this curve for seasonal diseases most often. So this, I can't tell if this is flu or COVID, but it's something like that, that has a very seasonal distribution. And these will be the weeks, each column is a week of the year. Where is also important. So where does a disease or a condition arise? You can look at geography. You can look at, it may not be specifically a characteristic of the geography of the place, but environmental exposures in that place, climate, latitude. Sometimes latitude and longitude can affect conditions for getting a disease, or the setting. Yeah, this is one. This, I think, is the kinds of snacks people were eating, and it's by setting. So at a restaurant, at a stall or a shop, at home, at school, and the different types of snacks people were eating in these settings. So that's also aware, right? When you're looking at that kind of setting. So then looking at why did the condition or disease arise, this can give us clues in our descriptive studies that we can then pursue further in analytic studies. And we've talked about the so what. There are a lot of descriptive reports. Is this important enough to do? And this is an important question to ask when you're doing descriptive studies, is what are you contributing to the knowledge that is not already there, right? Because there are a lot of descriptive studies. So you just have to make sure that what you're doing is providing information that's up to date. Maybe it's been 10 years since the data you are collecting has been collected. Maybe it's a new population. Maybe the population has changed. So those are things to consider. Is the condition current and timely? Will it have a broad societal impact? Has it been studied before? Is it political? That's often important in our ability to change. So to plan a descriptive study, understanding the uses of it, comparing the different study designs and the bias associated with each, and then choose the study design for your goal. Know what to consider. So what do you need to include in your methods, in your measurements, in your data collection, in your sampling, and then be able to calculate the associations or the measures of disease frequency, whatever it is that you're interested in gaining from this study and controlling for the bias. So this is going to be the same pretty much for every study design. You have to go through the same set of questions for every different study design you choose. So again, what's the best study design? There is no best. There's the right study design for your question, right? And descriptive studies are hugely important. They are the foundation upon which we build analytic studies. Okay, types. I'm not going to talk very much about case reports. Again, these are really just for reporting like the first case of something. I think the example I have is, so this was pneumocystis pneumoniae was the first indication of HIV in the United States. This is a case report of Zika. So these are important when something new and different is happening. But these are usually done by clinicians. So this may be less likely to happen among this group. but they're important for recognizing, describing new diseases. There aren't any measures of disease association. So let's talk about what do you know about ecological studies? Anyone familiar with ecological? So often what this means is when we take a measure on a population level and we compare it with other measures on a population level. So if you take the prevalence of, say, stunting for 10 countries and you compare it, and you're talking one measure for the whole country, right? Just a prevalence. And then you compare it to some other country level measure, say, GDP or median household income. Does that make, so you're talking about two different measures that are an aggregate of the population. These are not things you're measuring directly from individuals. So if you do these studies, you can only have an association then at that country level. You can say, well, countries with this kind of GDP tend to have this kind of, this prevalence of stunting. But what you cannot say is that every child who lives in a country with this level of GDP is stunted.
So we did not access directly to the respondent.
Right,
We don't have respondent. We only have data.
exactly. That's a great way of putting it. We don't really have respondents. We have data. So it's often aggregate data. I'll show you, but they are good for environmental and some of these kind of socio-political factors and hypothesis generating. So it's something you can look at. There was an important one, I might have something, but so this is child mortality versus prevalence of child wasting. So it's just showing you that the correlation for each country between their child mortality and their prevalence of child wasting, and it's laying that correlation on a graph with the same outcome, same measure for all of these other countries. Really, it just helps you gain a picture of how you may see child mortality and wasting correlated and whether there's some regional differences. So this has a lot, there's a higher prevalence of mortality and wasting in what's purple, which is Africa in that region. And this can tell you, what can you determine from this graph? Are there any thoughts that come to mind when you read this graph? Just if you look at this graph and you look at how these measures are distributed on this graph, does it make you think anything? What do you think about the relationship between child mortality and prevalence of child wasting?
We try to look for a correlation.
They're all correlations. They're correlations for each individual country. What does the distribution tell you? You also have to consider the color is the region.
It's true.
Is there anything that stands out?
So the
color is representing the country, right, in region.
Yes, the color represents the regions.
Africa has the highest
mortality.
highest mortality rate.
So you're seeing that among the African countries, there's a higher mortality rate.
About the region. At the same time, the more prevalence of child wasting, the higher rate of child mortality.
Okay, so maybe you see that the higher the prevalence of child wasting, the higher child mortality. Are there exceptions to that though?
India, yeah.
So,
Except there's maybe a high those country which has higher economic status. I don't know.
well, it's hard, right? I mean, it's hard to say, right? Like,
Yeah.
we don't necessarily know
Yeah.
why.
Why? Yeah.
But when we look at this, we can say, well, Sri Lanka has high prevalence of wasting, but very low child mortality. And same with India, or that, Lesotho, I think is up there, has higher child mortality, but a lower prevalence of wasting. So does this test a hypothesis or generate hypotheses?
Is you generate hypothesis.
Yeah, it's getting you thinking, right? You're going, I wonder why.
What happened?
Yeah, what's different? What's different about these countries? And what's different? Is there really, what is this relationship? So just descriptive studies in these, especially these ecological correlational studies, can be good for just making you think about some possible hypotheses, looking at distributions. Did you want to add anything?
No.
You have, okay.
And just.
Yeah, yes. Okay, this is another, so this was a more population level because it was population-based data sources that were reporting to federal agencies in the United States. And it's a lot to go into, but basically the only way we could measure some of these, the impact on COVID-19 vaccination, on emergency department visits and hospital admissions and deaths, was looking at this higher level data, because all we had was the reporting that we were getting from hospitals or from state level data sets. So this is an ecological correlational study, because we're not able to measure each respondent. We're not able to capture the cases. We just know that this hospital had this many, and how these curves change after we implemented a COVID-19 vaccination program. So it's easy to see something at a glance and understand what some of the correlations. I mean, what would you conclude just by looking at this? Did the COVID-19 vaccination program help reduce hospitalizations, deaths, emergency department visits and cases? What would you think looking at this? It happened.
Go ahead.
What changed? What?
Sunrise after the vaccination implementation.
Yeah, so after the vaccinations, these all went down, right? Emergency department visits, cases, hospitalizations, deaths. Now, we can't directly say that COVID-19 vaccination reduced all of these, but we can look at this and say, the data from states, from hospitals, is showing us that after we implemented a vaccination program, there were many fewer deaths, emergency department visits, right? Okay. And this one, I'll just talk about this real quick, but this is one I've always has been, it was sort of close to my heart as an ecological correlational study. This Robin Hood index was a measure of income inequality. So the difference between the richest people in the country and the poorest in the country. Because for a long time, we talked about just that it was poverty or being poor that was related to poor health outcomes. But over time, we've understood that actually income inequality in a country contributes more to poor health outcomes than just abject poverty, if that makes sense. But this is one of the first very high-level ecological studies comparing this Robin Hood index, this measure of income inequality in a country. This is in states, in the United States, and the age-adjusted mortality. So in states with higher income inequality, like Louisiana, Mississippi, these are states in the southern United States. They have very high income inequality and very high mortality. And they were able to lay a regression line on this correlation and show this association of the R was 0.54. So this was the first kind of ecological study of state level income inequality and mortality. So that led people to do more studies and say, oh, okay, maybe we need to look at this inequality more than just the level of poverty. We need to look at these states that have very, very rich people and very, very poor people and look at how that impacts health more than the states that are all very rich. Utah is Utah, New Hampshire, very low inequality and a lower mortality. Utah always does kind of the best in health outcomes in the United States. Do any of you know anything about the state of Utah by chance? It's not, I wouldn't expect that you would. What is it?
Utah?
Utah?
No. What do you have about the
Yeah, if you know about anything about Utah, the state of Utah.
Utah?
Yeah, it's a state. So I'll just tell you. But in Utah, there's a very large population of a specific religion called Mormons. And in general, they don't drink alcohol. They have a very kind of healthy lifestyle. There are other problems with the religion in general, but they abstain from alcohol, from drug use, from smoking. And so this is partly why Utah always performs better. But they also have a lower income inequality because there's a lot of just it's not a highly populated state. And this may have changed after we had a massive hurricane in the United States. A lot of people were displaced from the south to Utah, and I'd be curious to see if that's changed since then. But
differences from this it seems kind of like when their index is increased, and mortality increase as well. So
yes.
Development is not
So what? So one of the arguments might be that you have to reduce the inequality to see healthier outcomes, to reduce the mortality. And ways in which we can reduce inequality in the United States are debatable, but some people may think of state programs that transfer income or supplementary opportunities for lower income that can help bring them up higher. No one in the United States ever tries to bring the rich down lower. That doesn't happen. But finding ways to help address the inequality is something that you might do.
Social selection schemes.
Social safety nets.
Yes, I'd like to think about the socio-economic correlations with this one. You think how like decline for those countries, they have the high income, okay, they have the high mortality as well.
Oh, okay, I'm sorry. So this is actually, it's not high income, it's income inequality. So a higher difference between the rich and the poor. Yeah, yes, if this were income, that would be odd, for sure. Yes, no, thank you for asking that question and clarifying. So it's the difference between the rich and the poor, not the actual income. So I'm gonna let Malupa talk about some of these studies, and what we're gonna, to wrap up just the ecologic studies, you're almost always only using a correlation coefficient or a linear regression, because you're just correlating high-level population measures. And if you want to look at what the hypothesis would be, there is no linear relationship between the two variables. That would be your null hypothesis. And your alternative hypothesis would be there is a linear relationship between the two variables. If you have an a priori hypothesis, you may say there will be a positive linear relationship or a negative. You may have some idea about what you expect in your hypothesis. But these are quick and inexpensive to do usually if you have the data. Like you said, because you just need it's the data, it's not the respondents. Sometimes you have to pay for secondary data, and that's tough, but you can generate many hypotheses from this type of study. So that's kind of a nice use of this. And it's also it's a common way that we might evaluate policies. So I'm going to talk about some of these other things tomorrow so we can,
I'm just smiling over the ecological.
You're smiling at the ecological fallacy. Yes. And I think we talked about this, that like, yeah, you can't take conclusions at the population level and apply them to the individual. So you can't say like, every single person in Utah has a low mortality rate. That's not right. You also can't say, so we can talk about more of that tomorrow as well, but let's let.
So one of the things I hope is clear, like Kate and I have been having these nice conversations about science, and last week with Carmen and Roger as well. And what you might notice is that we have different opinions about things. Like, the strength of evidence required to say something causes another outcome. Like Kate has a very strong requirement to make such a statement. I have strongish, but maybe a little bit less, and then Roger and Carmen, I think Roger has maybe like absolute, we have different views, and you are going to have different views too. There's not going to be exactly a right answer, but you have two goals, right? You want to know the truth, but you also want to be confident in what you say, that you feel like you can justify. And there are not, a clear answer that you can know is true. So that's why there's this discussion and debate. And if you ask for people like Carmen and Roger and me and Kate, we will all have 4 different answers for something. And that is very normal, and that is part of the debate. So that relates to this. So you looked at the project. So I think even before we started the workshop, we shared 2 papers about ultra-processed foods. I hope you looked at that because now we're going to talk about it. Oops, let's not get carried away. So there was kind of more of an opinion type piece that was by Hall. That was Kate. These are 2 papers from this year that was talking about ultra-processed foods. And then there was a review paper by Valicente and others. And they were both from, does this sound familiar? I hope you looked at these papers because I'm going to ask you questions. Yes? No? Familiar? You looked? Okay. Let's see how this goes. These are homework, people. you have to look. And one of the papers is relatively, I think, short and was more easy to read. The other one was very long, had a lot of technical detail, so many references. So it's hard sometimes to absorb so much information. But we'll talk big picture. And these things both papers are kind of debating about what ultra-processed foods and the effect that they have on health, right? There's an argument that one of them makes that says, here's ultra-processed foods. They seem to be affecting weight gain. And as we know, overweight and obesity is becoming a big problem in the world. And we know that overweight and obesity is related to increasing our risk of non-communicable disease. So the question is, what should we do about ultra-processed foods? So before I get into it, I just want to give the short thing, and I'll share these slides with you. In the papers, they talked about this thing called the NOVA classification system. There's a reference here with the link, and so when you get this, you can really look and look at it. But basically, it's a way to categorize food based on how it's made. So you have 4 categories. And the first one is kind of unprocessed. So when you eat a fresh fruit, you don't do anything. You just, take a banana from the tree and you eat it. So unprocessed. You might have maybe minimal processing. So maybe you take, a fruit and you make juice. You just squeeze, you have juice. So it's minimal processing. The next level is where you do a little bit more processing. So for example, when you take something and you press to make vegetable oil. So that's kind of the next level, group 2 of processing. And again, when you get this, you can see all the details and read all of these things. And then there's processed foods where you do different kinds of methods. For example, you can do canning, you can do fermentation, you can do like when you take milk and you make cheese. Those kinds of processed goes here into this kind of processed foods. So if you have, things that are salted and preserved, those kinds of things, fresh bread would be kind of in this, baking would be in this category. So all the things that you're doing to food to kind of change it in different ways. And then the last category is this ultra-processed food. So ultra-processed is where you do even more kind of processing to change the food into something. So when you think about Coca-Cola, right? It used to be sugarcane or, corn, and somehow it becomes this drink, right? Like that would be ultra-processing. Yep. Did you want to say? What's that?
Pepsi there.
There's Pepsi. Okay, Pepsi too. Mirinda, Fanta, all of those things. Sugar-sweetened beverages. If you go and see, and I think all these kinds of packaged foods that are kind of different flavor, like maybe they're like little crisps and they have a shrimp flavor, right? There's no shrimp you can't see any kind of shrimp, but it has that flavor, right? And it's crunchy, salty, can be quite nice. Like those kind of things that come in a package. A lot of them, I see them In Laos, I see them a lot of them are imported. They might come from Vietnam or Thailand or China. They're nice snacks, potato chips, things like that. So there's a lot of things that you do to food, usually in a factory kind of setting or like with some machines to actually make this kind of food, right? So that's the food processing. As you do it, you might do other things. You might add salt, right? You might fry, add oil, add fat. You might add sugar, like a lot of sugar to make something sweet. You might add nutrients. So some things are fortified, right? Like you might buy some kind of cereal or granola or something, but they also add vitamins and minerals. So it doesn't have to be bad. It might be good. You might add preservatives so that something can stay for a very long time. So there are other things that might be added to the food. So this is this category of ultra processed foods. And the common dialogue, well, actually you can tell me, the two papers, if you looked at them or are looking at them now, have kind of two different opinions about the effect of ultra processed food on body composition and weight gain and how that is affecting health. And the implication is like, okay, if there's some negative effect, maybe we should do something to control ultra processed food. That's the idea, right? So did you guys look at these papers, or do we need to can someone who's looked talk about what are the arguments that are coming from these different? If I'm smiling, I'm going to call on him.
It's I think it's quite related together, like a support system. They talk about the diabetes, right? Disease.
Mm-hmm. About what? Diabetes or what?
Yes.
Or food?
Sorry. Obesity.
Yes.
Obesity.
Obesity. Yeah. What about obesity? Exactly. What is it? What do they say?
In the paper, it says that the highest list of the obesity is increased.
Yes.
Yeah, around of the country.
So obesity is increasing, and how does that relate to the ultra processed food?
Because the people in this have eating more, the variety of food consumption make the people that the lifestyle changing.
Right. So people are eating more ultra processed food, the body weight is increasing, and therefore there can be this negative health effect because it's increasing risk of NCD. Right? That is the argument. And how do they know this is true? Like what kind of study gives this kind of information?
I think for other bodies who haven't read this, maybe you kind of give some kind of specific information for us to decide. There are a lot of us here having read it.
Okay. We can also postpone this till.
But when I read that paper, the paper is not, it doesn't show the table for statistic to show the figure or
right. Yeah. So one of the papers, okay, and we can let's talk. Maybe we can talk a little bit about it now, and we could revisit this later in the week. So a few things. Let me suggest. Let me find the paper if I can. One second. Where did I put my? Okay. Okay. So both of these papers are not original research. One of them is kind of like an argument, a discussion, an editorial. They're trying to give an opinion about what they think is something important that we should, as researchers, as policymakers, we need to pay attention. So that's this paper, is trying to make this argument. And reading this is a little bit different, right? Because there's no p-value, there are no tables, that sort of thing. I think sometimes, and it would be great to hear Kate and for others, sometimes when I find this, like sometimes reading is, I don't want to say reading is difficult, but sometimes it's difficult, right? So especially if it's not the language and so, or the topic is not so familiar. So the abstract is very helpful, right? Like if you start with the abstract and just try to understand what they're trying to say, or even take notes. The other thing I find helpful sometimes is to read introduction and discussion. Like, yes, there's some things in the middle where they give lots of details. And especially in the other paper, there is so much detail, right? This one, it's very long and they have a lot of discussion. And you just wonder, like, what is this paper about? So I think, like, sometimes when I have a hard time reading, I will read the abstract because it's short, it gets to the point. It gives me an idea of what to expect. Sometimes then I can read the introduction, sets up a problem, right? Like, why are they bothering? What do they want to do in this paper? You know, what is the background? And the introduction, it's usually relatively short. And then I skip. Like later I'll come back, I'll read everything properly, but I'll skip the middle because the middle has so much detail, so much information, and sometimes it's too much. I'll go to the discussion because the discussion will explain the so what, right? Like you have so much information, so much experience, and yes, it's a review paper, so it's not going to give any p-values or tables. I think there's one table, but it's not really very much. Here, actually, they don't call it discussion, they call it conclusion. And so they kind of explain, okay, you have this nervous system, it's trying to do things, and it's only one page as opposed to 20 pages. So it gives me the big idea. Then I have the big idea, the big picture, and then I go back and then I can say like, okay, what did they say about this very specific topic? You know, I can go into those details. So try that when you're reading. Try the beginning, try the end, and then the abstract first, beginning and end. And then when you're ready, you can look in the middle. What do you think, Kate? Like when you're trying to read something and you have a lot to read?
Yeah, I typically do that too. Although I'm also probably because of my methods focus, sometimes I go to the methods first, and then like abstract methods. I want to see the conclusions they've drawn. Yes, so their conclusion or discussion, and then I usually go back and see how they, to the intro, see how they justified doing the study. I think, or but I'm I'm interested in like who's the population, what did the study design look like, but yeah, what are the conclusions they're making from?
And then do you believe them or do you feel like it's supported? So you may not read the result, but you might look at some tables or something as you go along just to like understand what's going on. So basically like sample size of 2, but sample size of 2, like neither of us will read from top to bottom, right? Like, yeah. Unless you like really this like the perfect study for your research and you want to read everything. Like, that's a very small % of papers that I read usually. Usually I'm jumping around. I don't have time. I want to get to the point. Yeah. And I'm not going to do, like I read a study in Brazil. Okay, I'm not going to know the details of Brazil, and it's interesting, but like it's not relevant to me that much. So I don't need to know all of it. I just need to know big picture. What did they find? How did they do it? What were their methods? And what did they conclude?
Although sometimes I do be jumping around and then I realize I just need to go back and start from the beginning.
Right. But you get the big picture and then you can like really engage with it. Like you know what to expect, right? So it's not like reading like a novel or a storybook, right? Like You don't need to read what page 1 to 10, like in order. You jump around. So everybody, I think, is different, but think about, like, it's okay to do it in a way that makes it easy for you. And not all the information is necessary. Okay, so that is the two papers. We can kind of, is there anything else I can say? Because we can come back later in the week, but I do want you to try to look at it.
Yes, I try to find conclusion, and I don't see any actual conclusion from this long paper. So I can,
The long one.
yeah, the long one.
Right. So I would say, just to kind of like my big picture experience of it is that here's a question. Is ultra processed food bad? Does it affect weight gain? Does it lead to obesity? It seems very obvious because in the last, I don't know, 50 years or something, we have more ultra processed food. We have more obesity. Right? So it sounds like one will cause the other. But are we sure? Are we sure? It's always this question of causality, right? What kind of study design can give you an idea of causality? It would probably be like an RCT would be the goal. They say the best level is the RCT, right? Kate had the pyramid of evidence, and on the top was things like RCT. You don't really have RCT. There's maybe one real study that looks at, and they talk about it in this paper. There's one study that they did where they looked at randomizing this type of food versus that type of food based on processing. But the study, I think it was like 20 people, 20 participants. It was a very, very small study. So the real evidence, this claim comes from what are sometimes called epidemiological studies. It's not randomized. It's this sort of cross-sectional. It could be this cohort study we'll talk about, I guess, tomorrow probably. Case control, like these other kinds of studies where you don't tell people what to eat, you just observe. These people eat this is their result. Those people eat that, their result is like this. You think it's because of what they eat, but it could be other reasons, right? So then the question is, okay, if you only have those epidemiological studies, should you go and say, okay, don't eat ultra-processed food? Are we sure that the ultra-processed is the problem? Maybe it's something else, right? Processing is just how you make the food, how you cook it, how you prepare it, how you make potato chips with machines and everything like that. Like it's a process of making some kind of food. But then there's also other things, like you add fat, you add sugar, you add salt. Maybe the problem is fat and sugar and salt. Doesn't matter if you are processing or not, right? So how do we decide, right? There's a very specific action. The first paper, this one, which is like an opinion. Oops, sorry. Oh, it's here. This one is making this argument that we need to do something about this type of food in the world, right? Both of these papers do have very much an American bias. So another thing I want you to think about is, like, does this kind of information, is it relevant to Lao? Is it very much an American problem? Is the same information, maybe it's not applicable, or maybe it's even more applicable to Lao, right? So you have to think about that too when you read these papers. Are they important for you? Does it mean that in your own country you need to think about policies for this type of food, or do you need more information? If you're not and what it is these are from two very, high reputation scientists, right? They're very rigorous, they're good scientists, but they have different points of view, right? And so how do you make a decision about your own point of view? Do you want to have more information? Do you believe one argument over the other? Those are the kinds of things you want to think about. There's no correct answer.
Also, I think also keep in mind too, is how comparable the arguments are too. Like, are they saying
Are they looking at the same thing, saying the same thing? Or are they putting it in context differently?
How do you mean?
Well, I'll wait until we're having the debate, I suppose, but
Yeah.
Yeah. Are they actually providing opposing opinions on the same issue? Or is it a little different?
Are they talking about two different subjects, not exactly the same? Yeah. Yeah, okay, all right, I guess we'll halt there. What should we do? Should we, we have examples of stuff in the afternoon. So we can go back to statistics. Or we could continue for a little bit more on your 5.2 or 6.2.
Whenever everybody wants, we have 20 minutes. You're already up there.
I'm already up there. My examples will probably, okay, cool, I can do that. Okay, I will share these things.
Actually, yeah, maybe having this slide as
while they read.
Yes, as
Yeah.
we read through might be really helpful.
Yeah, I'll send it to you, Hui, and then so think of these questions, like what is one side saying, what is the other side saying? And then, what exactly are they disagreeing about? And in your own is this applicable only to Americans, or is it applicable more broadly? Is there anything you don't know, like questions you have? Before you want to make your own judgment, like you must have questions. So what kind of questions are those? And then what do you think? And then science will continue, right? People will do more research. They will learn more things. And maybe over time you have a certain idea now, but that idea might change as you get more science. You see more studies, you see more evidence, you might change. So what might change your idea in the future? And that happens a lot, right? Like and this is especially true in nutrition science, right? Like there was a time where people used to worry a lot about energy insufficiency. And then we became focused on protein. Then maybe in like 1980s and stuff, we started talking about micronutrients. And then we said protein was not important. Now we're talking about protein again. Like things go in cycles. There's debates, there's new evidence. The context is changing all the time. So things will change and your own opinions are going to also change. So I will share this. Let's see. It's okay if we're not exactly 17 minutes. Like lunch can be like a few little, okay. We could do one little example and then let's see how this goes. Okay. All right. Want to do statistics? Anybody?
Yeah.
Okay. Was that you, Kate, that said yeah? Okay. Thank you. All right. Okay, let me refresh. We talked about this paper last time. Remember this one? Yeah? Okay. Okay. So just to remind you, this was a study that was looking at safety and efficacy of iron supplementation during pregnancy in places where there was malaria. Yeah? And so they did a randomized control trial where they had pregnant women coming for antenatal care and they gave them iron or they gave a placebo, which was basically a pill that looked like the iron pill but had no iron. It was just like inactive ingredients only. And then they looked at various outcomes. So it was randomized, it was double blind, means that the women did not know what they were getting. The researchers, we didn't know either. But the women got that all during pregnancy. And then we looked at pregnancy outcomes, perinatal outcomes, and outcomes for the child and the mother. And we looked at both safety issues and also efficacy, like hematological status, anemia, and so on. So we talked about a few different outcomes as an example, but I just wanted to go back and talk about this. So anemia at delivery. And I want to do this to kind of introduce and remind you of the chi-square test. So we can practice the chi-square test with just this example. Okay. So anemia, it's defined as the hemoglobin concentration being below a cutoff. In this particular case, the cutoff is 11 grams per deciliter. And so this is looking at anemia rates. You have women who are getting iron, women who get the placebo. At delivery, you had 144 cases of anemia out of 481 women. So that's 29.9%. And then here you had 501 women get the placebo, 248 or 49.5% had anemia at delivery. And so we want to compare these two. We looked at relative risk. We talked about this a little bit, but let's not worry about that right now. Let's look at this. And there was a p-value, something was significant, right? So can you, so you got this in your head, yeah? Let's just kind of talk about what is the research question here? This test, it's doing a statistical test. The p-value is significant. Everybody's so happy. Like, what is the research question?
Iron and prevent the anemia.
Yes. It reduces the risk of anemia at delivery if you get iron. Does iron during pregnancy reduce your risk of anemia at delivery? Okay, that's very good. So what's the hypothesis?
The pregnant women who are receiving the iron can be decrease the anemia.
Yes, that they would have a lower risk of anemia if they get iron, right? That's a very reasonable hypothesis. So in this statistical test, let's think about it in terms of a chi-square test. What would be the null hypothesis?
Not different between placebo and iron. Not different between glucose, if iron and placebo.
What is not? What is the
Mean of hemoglobin.
You know, better.
Hemoglobin between two.
what is the thing?
Hemoglobin not different between two.
And this is anemia. Either you don't, yeah, you just have anemia or you don't have anemia. What that's a what do you call that? Nominal categorical outcome, right? Anemia is yes or no.
Mean.
So yes, you can do. Yeah, you can do mean, and we did do mean.
Okay.
Mean was
Iron.
was here. Here's the hemoglobin. Here's an actual number, but this particular one,
Anemia.
I'm just using anemia. Yes or no? Yeah.
Different. Anemia not different between two.
So, but exactly what about anemia? Is it just anemia? A group doesn't have anemia. One woman has anemia. So, you can say maybe the incidence of anemia or the risk of anemia, right? You need some kind of number, right? So you want to say maybe what is your chance of anemia if you get iron during pregnancy, right? It could be like a probability. And I think that's how Roger presented it, right? You can say he always had this P and he had and whatever, but it's just a probability.
Or proportion if you're in a kind of cousin.
Incident.
With anemia, yeah. Yeah, you can say it as incidence as well.
Incident is the name test. It happens within anemia not different.
No, Ilan.
Incidence is technically different, but in the case of pregnancy, it's not really, because like delivery, like it's one time, like that is the time. Usually incidence is sort of like the disease happening per amount of time. But for pregnancy, there isn't any real amount of time, like you deliver today and that's it. Like, so in the special case of delivery kind of outcomes, then it really is like incidence and proportion, prevalence, all of these are kind of the same. So what you're saying is like, I have a chance of getting anemia, and our chance if I get iron, let's just call it, I don't know, I'm gonna use a shorthand. I'm just saying my chance when I get iron is the same as the chance of like placebo or no iron. Honestly, nobody in real life is like placebo. It's like no iron, right? That's what I'm saying. I have a chance of anemia. We know anemia is very common in pregnancy. So it's not the fact that it's going to be 0. It's going to be something. But that chance, it does not matter whether I get iron or not. That's the null hypothesis. And of course, that is the opposite of our true hypothesis. We really believe that if you get iron, your chance should be less. Right? That's our hypothesis. Our hypothesis is usually like the alternative hypothesis. Right? We think that if you get iron, our anemia risk goes down. And if you get no iron, it should go up. So, but the null hypothesis is that this iron, which is the treatment or the intervention, has no effect. Right? So we say the chance is here and the chance is here. But now in real life, okay, so I'm just going to erase this. And this usually, it's a statement about the population. So we're not talking about just these few, I had maybe 1,100 women here, right? It's not those women, it's all women, right? All women who get iron should have a reduced chance of anemia. And the ones who don't get iron should be more chance of anemia, right? But in my sample, what happens? What was the proportion that had anemia if they got iron?
39.9.
30, yeah.
29.9.
29.9, yeah. It was like 0. Let's do round, because yeah, it's easy to say 30 or 30%, right?
And the other thing is 50%.
Yeah. 0.5 rounding. So, I mean, it looks different, right? It looks like, and it kind of fits what you were expecting, but, you know, is it statistically significant? Now, this is a big difference. So you would say like, look, man, it has to be, iron is really making a difference, right? But suppose it was 0.30 and 0.33. Maybe that's just bad luck, yeah, right? You know, like it's just chance. So if it's a big effect, okay, you really think something might be happening, but at what point do you go from not sure to sure, right? So that's why we do the statistics. So one way to do this is to do this chi-square test. Okay, so how do we do this chi-square test? I'm going to switch between, let's see, I'm going to keep that there. And you guys have the PDF of this. So if you need to see big, like try to find that from Hui and you can make it bigger. And Kate, you were telling me it's always treatments and outcomes, right? Yeah, in every view. So let's fill this out. Actually, you know what? Let me do it in Excel. Let me just do it here so then you guys can see a little bit better. Make this really bigger. Iron, no. It's all placebo, just to make it placebo. Anemia. Anemia. And I can make some totals. Can you guys tell me the number in the iron? How many had anemia? 144, right? Yeah. 144 out of how many total?
481.
481. Okay. And in the placebo, how many had anemia? 248. 248 out of 501. Okay. So I can, so if I want to figure out the difference here, how many had no anemia, it would be this many, 481 minus that, right? So this one will add to 41. So this many must not have an anemia. And then here, 501 minus this. So 253 in the placebo group had no anemia. Is that okay? And then I can take the sum, right? So in the whole sample, let's just take this way. So the whole sample, I had almost 1,000 women for whom I have the result. And of this 982 women, I had 392 who had anemia. There was 144 in this group, 248 in this group, but that's the total, right? So the total amount that has anemia. And if I want to look at proportions, right? Kind of, let's call it P, yeah, probability. Yeah, right? I just divide. I just went 145 by the total, and I'm getting that 2.9, 30%, right? And I divide this number by this number, the number of anemia divided by the total. So let me just do that. And I'll just make it percent. Yeah, is that okay? Everybody is okay so far? So in the anemia group, in the iron group, I had 30% anemia. This is what you were telling, oh, sorry, I erased. That's what you told me before. Placebo, I had 50% anemia. And then in the whole sample, if I just ignore who is iron, who is not iron, it's 40%. Okay, but you can see that there's that big difference there. Okay, so that's fine. So now our null hypothesis, I should fix that again. I called it iron. This is the chance of anemia is equal to P. Or no iron. Right? So if the null hypothesis is true, right, what would I expect? This is what I saw. 30% here and 50% here. What would I have expected?
For analysis?
Yeah, if this is true, like suppose like, okay, in my sample, I see there's a difference, but like, I'm saying that in the null hypothesis, let's assume this is the truth, right?
So
Then these two numbers should be the same, right? So probably what I would, if the overall sample, 40% of women have anemia, you would expect 40% here and 40% here, right? So you were expecting 40% and you got 30% in this group. And you were expecting 40% here, but you actually got 50.
If we expect 40, right?
Yes, if these two things are the same, your risk of anemia, and this is the kind of key idea here. Because you remember Roger kept saying observed and expected and observed and expected. So what does he mean expected? Expected means if the null hypothesis is true. Let's forget what we think, our null hypothesis. Let's just say like, we made this null hypothesis. We say that this chance of anemia with iron is the same as the chance of anemia with this. If it's the same, then what is our expectation? Right, but in terms of numbers, if in the whole sample, the prevalence of anemia is 40%, then in each group, it should be 40%. Right? Sorry?
KTM, we have to, reject the.
Let's wait, let's not jump, we're gonna go there, So, this is observed, right? This is what we got.
Sure.
But expected. If, let's call it H0 is true, right? If this is the overall 40%, right? We would expect 40% here. Everything would be 40%.
In that case, we don't reject that numbers, we reject the error.
That is our null hypothesis.
We actually reject the error one.
It's null hypothesis, right? That's what we would say. If iron is making no difference, then every group should have the same amount of anemia, right? Everybody should have 40% anemia. But that's what you think. But then what you find is in iron, it's reduced. And when you get the placebo, it's increased, right? So this is the difference observed and expected. And the idea is, if there's a certain expectation here with the null hypothesis, if the reality, your data is very different from this, then probably that's not true, right? Here's what we thought, if iron is making no difference, and here the deviation is so big, 30% to 40%, 50% to 40%, you can't believe this anymore, right? It doesn't seem likely. You have your data, doesn't seem likely. So we should reject this idea. And the alternatively is to say that there is some different risk of anemia if you get iron. And actually it suggests that it's substantially reduced. That's the idea of the hypothesis testing. And that's true for all hypothesis testing. What's happening is this. Okay, let me just put it aside. So every time we do this, we have a research question that is about real life. We make our hypothesis. Our null hypothesis is usually the opposite, right? We're doing this work because we think iron makes a difference, right? The null hypothesis is that it makes no difference. And then we say, okay, what do we expect? And then we look at our data and say, is the data what we expect if this null hypothesis is true? If it is or seems similar, then okay, maybe it's true. You can't reject this because the data are consistent with this. But in our case here, the data is really inconsistent with the null hypothesis. So you get rid of this and you go to the alternative, which is that these things are not equal. That's the idea. So the ways you can know is, so you're asking, does my data fit this expectation? And the ways you can know this are two ways. One is that you calculate a test statistic. And there are many formulas, and you saw that from Roger, and it gets very complicated. Doesn't matter because Excel or Stata or SPSS, they can make that calculation for you. Every test statistic is just taking all your data and all of your expectations under the null hypothesis, puts them into a formula and compares them, right? It's just like one number that tells you how far your data are from the expectation under the null. And so if that number is usually big, then you're like, okay, my data are too far from this idea, I need to reject. The p-value is the chance that your data is happening just by chance, that this is true, and it's just unlucky that you had 30% and 50%. It can happen. I mean, it's possible just by chance. That has nothing to do with iron, it's just, randomness. But it's very unlikely. I mean, if it were 30% and 33%, okay, that's very possible. But 30 and 50, it's not likely, right? So those p-values are small. The chance of it happening just by bad luck or good luck or whatever, by luck, is very small, which means that it's probably not luck. It's probably that there's a true effect of iron, because luck has a small probability.
What might affect that chance?
Yes. What might affect the chance?
The chance of
this being,
just random,
error,
yeah.
essentially. If you're doing this study and you had, I don't know, 4 women in each category, in each of your 4 cells, maybe, or 5 or 6.
Do you think it's an area of measurement of anemia as well?
Yeah, yeah, so it could be errors of measurement of anemia. It can be sample size.
Yeah, so sample size you can have a true, the relationship that you can't find it because of your sample size. It won't, it won't pass, it won't emerge. It's gonna fall into the, null hypothesis because of your sample size. And ultimately, you can have a really big sample size, and then many associations are statistically significant because your sample size is larger. So you have to look closer at the effects.
Let me illustrate like this point here, right? Like, look, here, when you say, can this be by chance? Like, we're talking 144 versus 248. That's like 100 women difference. Probably not by chance, right? Like this number, it's, okay, the total is not exactly equal, but it's close. It's close. Total numbers in each group are similar. And yet these 2 cases of anemia here are 100 more in the placebo group. So it's probably not chance. But suppose you had the same scenario. Let me just copy and paste. Suppose, let me get rid of everything. Suppose you had 10 women in each, and you had the same 30%, so 30%, 50%, 40%, oops, percent. Then this would be just 3 women, right? And 7. This would be 5 and 5. And then this would be 8 and 12. 3 and 5. I mean, maybe you just picked the wrong 3 and the wrong 5, right? Like that can really be, so if you had a sample size of 20 women in your study, like, even though the numbers are 30% and 50%, you're not that confident that this is truly different. But if you have almost 1,000 and you get 30% and 50%, now you have some confidence, right?
And the relationship may be true. It may be true in both, but you can't show it, demonstrate it in a smaller sample size because you're not going to be able to reject the null hypothesis. It's going to fall in that area. James.
Okay. And actually, so if you do this and you do the calculation, you do it on Stata or SPSS or whatever, you'll find the p-value is very, very, very small. It's like 0.000. It's very small, which means you reject this, you say that clearly this is lower. The anemia under iron is much less than anemia with no iron. And I think we can, okay. So that would be our conclusion. Let's stop there. There'll be more examples afterwards. Just to warn you, let's see. The one after lunch that I'd like to talk about is something that I think you got from Hui as well. I think towards the end of last week. It's this one. So look for this one. Yeah.
So regarding to example, so it depends on how much sample could be to make it sure that to make that relationship to be stronger, or the evidence to be more strong. And how we do how large it should be best for such a certain amount of the population. Because
That's the third time power has come up.
the
So,
sample size determination, you have already calculated based on its prevalence, based on that effect, something like that.
Yes.
yeah,
It's
Yes, you
95%,
determine that before-
yes, yes.
Yes, before you begin the study. And we will, I think, I can't remember where it is, but I.
Somewhere in
I'm
topic
sure that
6.
We go through every info and some of these ways to help calculate
The power-
power and sample size. Yes.
and you notice it's tricky because power calculation, there's a proper way to do it, but it's also a lot of guessing. Because because you know, the power that you need, like if the true difference is this big, you probably don't need 1,000 women to find a difference this big, right? You definitely need more than 20, but 1,000 is a lot. I mean, you're doing like, you know, this is very expensive, lot of labor, a lot of staff, a lot of laboratory tests, you know, like, but you, before you start the study, you don't know the difference is this big. So you have to kind of,
Yeah.
Yeah.
Yes.
you have to come up with a number. What do you want to detect,
And
right?
this sample may not have been powered based on just detecting a difference. It may have been also based on the regression.
Right. It was actually based on a different outcome.
Yeah,
Yeah.
exactly. So it may be, yeah, this could be overpowered, but the initial power wasn't based on just looking at these differences. So, and also like if you want to do multi-level or multivariate modeling, like you also have to take into account the other variables you're going to include in the model. And so it is messy sometimes, but
It's, yeah.
And what if I'm not so satisfied with the result I got purely from this sample? Can I do any other process of sampling over or do over sampling or additional sampling for that?
In an RCT, that would be very hard. That would be very hard to do because you have a budget.
But for example,
And you-
from routine maybe.
What's that?
From routine maybe.
Routine what?
Routine for those who oh yes, back to RCB.
No, yeah, that's,
it'd be a different approach, though. Yeah, yeah.
it would be, but you know, like, okay. Not giving iron during pregnancy has a high risk, right? So this sort of thing, RCTs are usually very regulated. You have an IRB, sometimes this one had an extra thing called a data safety monitoring board. And that's an extra body that is like outside body who is looking at the data, the study, at the results as you go. And so it was, and the reason why is that, you know, lack of iron can lead to mortality. You could have a maternal death. You could have child death. Like, it's a very serious thing. So you can't like just decide I need to increase the sample size. You know, it has to go through a very careful, and the thing is you're looking at your results and then you're deciding. So you're kind of, it's creating an opportunity for bias.
Yeah.
Right? Like maybe you're not happy with this, like maybe it's not significant, but the p-value is so close, like it's 0.06. And if you just had 100 more women, maybe it'll become 0.05, you know?
You just
Like,
gotta do it for next time.
yeah,
Yeah.
that is the chance you take. And like when we do the power calculation, we do a sample size calculation, you kind of take that into account. You say there's so much uncertainty, but I wanted
I like try to overestimate some.
within limits, because you don't want to over, like if I had said,
Rounding.
you know, with rounding. So
And actually, you can use what your response rates of nutrition would be, or like response rates, and say, well, we're gonna collect this 500 people, but we expect like an 80% response rate. So I'm basing my calculations on this. 80%.
like losing 20%.
Yeah, losing 20%. So
So that is okay to do. But what's not okay to do is to say like, okay, if I do 2,000 women, I can be very, very, very sure. Because there's a balance between being very, very sure and the potential for harm.
yes.
And especially with pregnancy, there's a huge potential outcomes in the child. So what is the long-term relationship between anemia status and maternal hemoglobin, and then child health and development? So they take advantage of this study population to answer this question. So it's not related to the intervention. It's just an extra research question that is interesting, and they want to ask that question. So a lot of times when you do have something like a randomized trial, like you collect so much data that you don't need, of course you should answer the main question, but you can answer many other questions as well, right? Like, and so you have good data, you can ask other questions. And this was one question. Is there any relationship between preconception, maternal hemoglobin, and child health and development? They used this RCT, it was called Preconcept. It was in Vietnam. They had over 500 or 5,000 women who wanted to have a baby, and they recruit them, and then they wait, because you have to wait until conception will happen. And then of those who are live birth, then they followed that mother and child. So there they had 1,599 children all the way. From birth, they had 1,599 children. So some women never conceived, some might have conceived, but maybe they had a miscarriage or something happened. But then they had a good number, 1,599, who did give a live birth, and then that child is followed. And as time goes on, you might have a child death. You might have, maybe there's migration and the family goes somewhere. Maybe they change the phone number, the contact information, like many things can happen. So you lose some children, but it's not bad. After 6 or 7 years, 1318 compared to 1,599, it's not bad, right? It's pretty good. So the things that they were interested in, the kind of X variable, the predictors, the thing they want to know is how affecting an outcome, was maternal preconception hemoglobin concentration and anemia. So this first one, so the mother's hemoglobin before conception, the concentration is a number, so it's a continuous variable, or you have anemia, which is that nominal, like it's either a yes or no for anemia, right? Those were the predictors. For the outcomes, they had many, many different kinds. So for the birth outcomes, you have the newborn's weight, length, is it preterm? What was the gestational age at delivery? Was it small for gestational age? They had several outcomes there. They measured hemoglobin concentration in the child as well, at 4 times. So 3 months, 6 months, 12 months, and 24 months after birth. Then they did some developmental outcomes. So in the young child at 12 months and 24 months, they did motor development and cognitive development. And then they did a more advanced cognitive functioning in the older child when it's in school. And notice like these kinds of things, if you read the paper, they make a point, I think even in the abstract, to say how they're measured. And this is always very important. Like when you think about yourself, when you're writing these things and when you're reading, some things are very standard, right? Like when you measure height, there's a certain protocol of how to stand and how to put the head, and it's kind of universal and it's fairly simple. But things like cognitive development, it's very difficult to measure, right? You need a lot of training and you need certain types of tools, and those tools may not be culturally relevant. Sometimes you need to adapt. So for example, this Bailey scale, I have used that in Africa, in Tanzania. And there, part of that involves like child playing with, like looking at a book or playing with some kind of toys. If you have a toy that's not familiar, right? If you go to a village in Tanzania and you give them some strange kind of toy, or you give a book in English or something like that, then how can they play with it? They don't understand, it's not familiar, right? So it's not reasonable to use certain kinds of measurements. So specifying what tool you use to measure and making sure that it's culturally like validated in the culture that you are going to. These kinds of things are very important and very difficult. So it did make a point of kind of saying these are the scales that we use, these are the types of measurement. Again, cognitive function is very difficult to measure. Another one, common one, is like women's empowerment, right? That is very cultural. Like, so you have to adapt. So measurement matters. So that's what they did. They had many, many kinds of outcomes on the child from birth until 7 years. Here's a kind of a tricky question. So what is the study design?
Control.
It was, but for this research question, are we using the randomization? It was originally RCT. It will always be an RCT, but we're not looking at the supplementation. We're looking at what was the mother's status, nutritional status or anemia status before, and then what happens. Of course, the intervention will affect the later anemia status, right? Because at the beginning, that's her original status, and then you give supplements or you give placebo, and some things will change. So you need to take that into account. But what we're doing here is actually treating it like a prospective cohort. Right? It's not about the intervention at all. It's you have women, you measure them, you watch what happens, you follow them, you follow the baby, and you just see what is happening. We are not randomizing, you have better hemoglobin. You can't control that. Someone's hemoglobin is their hemoglobin, so it's not randomized, but we want to look at that relationship. And why does that matter? Like to realize that the way that we are looking at this is not necessarily RCT. Does it matter? I mean, data is data. We can analyze anyway. What's that?
Can you repeat your question?
Like what? So I said, what is the study design? We said, okay, it's prospective cohort. We're just following this group of women and babies. Mm-hmm. But then why does it matter that I need to know cohort versus case control versus RCT? Like why is that important to identify the study design?
I think that's when you set up your study design, for example, like cohorts that we have two types of the cohorts, mm-hmm. prospective and retrospective. But this one that prospective that you follow up mm-hmm. until the outcome happens. Mm-hmm. It's different from the retrospective. Retrospective that you go back mm-hmm. for the like a recall.
Right, the past history.
Yeah. Uh-huh. So this one that you set up your time, but for example, like you already know this one will happen when they have the baby, right? Mm-hmm. Because that your outcome you want to measure the baby, mm-hmm. and for example, this one that you measure the anemia or hemoglobin concentrations for the baby when they have the 3 months, 6 months, 12 months, or others, or until they are 6 to 7 years. Mm-hmm. That time that you want to know the how much of concentrate of the hemoglobin.
Right.
Yeah.
But why do we need to specify? Like, how does it change anything? Like, suppose I say, like, okay, I think it's retrospective cohort, or I think it's RCT, and you say it's perspective. Like, does it matter? Can I just do the analysis and it's the same anyway? Or how is it different?
In terms of the analysis,
mm-hmm.
For the data,
yeah,
sure. Collect the data that, for example, if you do the retrospective, when you record reviews about the documents, for example, you say you have the criteria and you can correct the 100 of the documents. And you can get the data, but it might be it's not exactly you will get the 100 and 100 or thousands documents and the full documents. this one as well as like you will create something of like the numbers of the participants who you lost during the time that you follow up and the data. In terms of the analysis, I think that it might not, for my opinion, that I think it's not different in terms of that you use the statistical. For example, like you apply the types of the statistical will pop up. You use exactly the same of the statistical, but the different thing is only the periods of time that you follow up.
Yeah, this is good. You want, are you raising hand? Also,
Maybe have more like yesterday, last week I heard the Rogers, he said that like observation and experience. Sorry. If the observation, we didn't do anything with them, but we need, but for this, I think we did something with them, like to give some fair, and we follow up something like it, and we follow what happened with them. Yeah, like a predictors and follow and can measure, like use the statistic for measure. We have the exactly outcome and we will follow. For my opinion about this project, they have the group, like a not compare group, but only one group, and I did something with them and follow up is which one it changes.
yeah.
And for me, that I want to give more the opinions about the in terms of the data analysis. For the retrospective, we might not control at the or control the bias or the confounding at the beginning of the plan. But for this one, that we can have something that we can control about the confounded. In terms of that, we put at the beginning of the study, for example, like in planning this one, and we can have the handle with the confounder since the beginning until the analysis. But for the retrospective, we might have the deal with the confounder at the statistical state.
Yeah, okay, you're raising so many important kinds of issues, so it's really great, I love it. I lost my black marker. Let's see, how is it? You see the black marker anywhere? Is it right over there? Did I take it back to my? No. We're all Oh, it's right there. Thank you. Thank you. I do that to my phone as well. Just leave it everywhere. Okay. So these are such nice points because it is a little bit complicated of the way it works, but it is being treated like a prospective cohort. But it's true that like that randomization matters. That can affect your analysis, right? So the short answer of why does the study design matter is there's two reasons. One is that it might affect the way you analyze, right? So to try and find the right analysis might require that. But then the other thing is what type of conclusion you can make, right? So it is a randomized controlled trial, but the randomization, that intervention they're doing of supplementation or not, is not our research question. So in our analysis, we have to take that into account because that supplementation will affect hemoglobin, possibly, but it's not our question. Our question is the maternal hemoglobin before any kind of intervention is affecting this child's outcome, right? And so we're treating it as observational. So, and then if we were randomizing, if we were interested in the supplements, right, we would have a nice RCT. We can make at least some evidence about causality, about interventions, supplements affecting the child hemoglobin or the maternal hemoglobin or something like that. But since we're looking at something else that we don't randomize and that we don't control, which is the original anemia status of the mother, then we can't really say it's causality. It's going to be an association. This woman's preconception anemia status is associated with this child outcome. But it's hard to say that it's really causing, right? I mean, we have some idea that there's some causation, but that strength of that argument is not completely strong because it's observation. So it is very tricky thinking about, thinking about what is the strength of evidence you're getting. This is a strong study design, right? Like, and you're measuring things very rigorously, you're following people. There's not that many lost. There are very few studies can be conducted like this over, 6-7 years to look at an outcome. So that's really, it's strong, but it might not be the top of that pyramid, right? And that's okay. So we're gonna spend, what time do we have? Okay, until 3 o'clock or so. Before I get into the results and what they mean, for Dr. Kate, do we want to talk about teaching demos? And what we're expecting later in the week and look for some volunteers? Okay, should I go ahead and say that? Okay. What day are we doing it?
I think
Thursday? We have 2 days scheduled. What's that?
I think Thursday.
Thursday, okay. So we are looking for some 4 or 5 volunteers to do something on Thursday where we want to have you come to the front for 5 minutes and do an example. So we've been talking a lot about bias. Are we going to focus on bias? Or maybe we'll work on it.
Yeah,
Okay.
yeah, I don't know, because I think we might talk about bias tomorrow.
Tomorrow. Okay. So we'll pick some topics. We'll pick some topics that you might want to teach to other people. And, so it could be something like bias or what is an RCT or, so we'll try and identify a few topics. And what we would love for some of you to do is just come and pretend that we are undergraduates and you teach us that topic, explain the idea, and then give an example. So, but really develop a good example that shows that concept. So, for example, if you're doing bias, if you have something in your research, or you saw somebody else doing research, or you read some paper in the literature where you see that issue coming up, and you can explain a nice example that illustrates the concept. And you can do it in Lao. We'll have Kelly and Dr. Rath, and we can help us understand. Everybody else can understand. And then we can just have a conversation about how to communicate these ideas. Because these ideas are kind of, they're not easy ideas. And when you're trying to teach other people, students, sometimes they just don't understand very well. So thinking of good examples, it's hard. Anybody want to volunteer? Oh, is that you? Are you saying yes? Your hand went like this. Okay.
Only one?
Okay, so Kat, you're gonna do it and you're gonna do? Or no? Not now. Thursday. Yeah, you have until Thursday. It's only Monday now.
We can prepare before. We can meet before the.
Of course, yeah, that's why we're mentioning now, so you have some time to think, what kind of example you'd like to do.
And you don't have to use any presentation, you can just talk. If you want to write on the board,
Yeah,
you can use whatever tools you would like. But you are not expected to use any specific tools.
Maybe you can think about it.
Yeah, so if you want to PowerPoint, like,
I have a teacher better that they can comment and not the boss.
well, no, it's actually worse than the boss. Yeah. Yeah, so you'll be the student and then someone will be the teacher. Yeah.
We'll give you all a little time.
Yeah, think about that, but
Each other to do it.
yes, yeah, I think so, yeah, you're free if you can make PowerPoint, but it's not necessary, you can just use the board, or you just talk. Or you can do whatever method. Thursday, so you have 3 days to prepare. Yeah, and only maximum 5 minutes, just not 5 minutes to explain the idea and give an example from your own, experience.
Somebody said that gender not equal.
What's that?
Only for the volunteer, only the. But I said not one more male.
Oh,
Should be two teachers for the Thursday. We have female one, so we need one more male. One male.
oh,
For each teacher.
gender balance?
Yes.
Wait, so who is volunteering? Cat?
For male. Male, 1, 2, 3, 4. Only 4 male.
Wait, sorry, you're one? You're gonna do one?
Yeah, meaning that we have coupon on Thursday and it's to make the gender balance. It should be one male.
Okay. Well,
Maybe we should have that again.
yes, but we're missing some people too, so, okay, but.
That's gone. Only have one of my hope. That we have to structure on Thursday.
Okay.
Yeah.
Okay, we'll leave time not to put pressure on people, so we have 3 days to figure it out, but be ready for that, because I think it would be nice, and again, in Lao, not in English, because your students, you teach in Lao, right? So that's okay, so we'll have Dr. Rathaponwi and Kelly can help us, so, yeah. And I think most importantly, like each other, so you can give comments to each other about, is it clear? Is it a good example? How can you improve it? Yeah, all of that. Just help each other a bit.
Right, Malupa and I don't need to understand. We want all of the rest of you to, yes, help each other and be able to say, yes, you did a good job explaining this, or ask questions as though you were a student.
I really felt when Dr. Kate when you were speaking in the morning, the words that you use have so much meaning. Like you can learn at like a very top level, but like you can hear it again and get a deeper understanding, and hear it again and get a deeper it's like deep water, like it's like you cross the same river, but it gets deeper and deeper. Like, and I think, and even statistics, it's like that. You can do t-test without thinking, right? Like just follow the rules and reject and don't p less than, greater than, whatever, without thinking, and you can just do it. Or you can like deeper and deeper understand it. And I think that's so it's not easy. It's not, when you're teaching it, it's not easy. Or even understanding, sometimes for me, it's not easy. Okay, so there are many tables of results, but they're very similar because they had many outcomes. So let me just focus on table 4, because as a representative example, let me make this bigger for me. Okay. So what is happening here? Again, I was talking last week and I said, like, many people do what I do here. It's like when someone is doing a PowerPoint and they're talking about somebody else's research, you'll just kind of cut out a table or a figure and put it on the PowerPoint and give your lecture. And so it's always nice to have as much detail as possible. So you see, there's a caption here that explains everything, that says, looking at association of preconception, maternal and offspring hemoglobin concentration and anemia status during the first 1,000 days. And then it has different kinds of variables, and then it has different outcomes. And then it has how many? 6 footnotes. And it seems like a lot, but like, this is good because, because I'm giving a presentation, I'm not showing you the whole paper, right? But like, if you look at this, you get a lot of the information. You don't have the methods, but you can get an idea. So when you're making tables like this, like, use your footnotes. Don't say I'm looking at X and Y. Like, here they talk about different outcomes. They say it's the first 1,000 days. Like, the more information, it's actually better. It's very helpful. So use all of this. Kind of look at these kinds of styles. So now they have child hemoglobin at 4 different times, and then they have child anemia at 4 different times. And for today, let's just look at hemoglobin. So hemoglobin, again, they're using the continuous variable. Anemia is this binary or dichotomous or nominal variable. There's many words for the same thing, which is not helpful. And then here, this is the predictor. This is like the X when we graph. So we are looking at maternal hemoglobin before conception, and we're taking that as a continuous grams per deciliter, or we just make it in an anemia, yes or no. And that is before conception, so it's against 12 grams per deciliter. So this is binary and this is maternal. And what I'm going to do is, and then many, many footnotes. What I'm going to do is just for discussion, I just want to do one small piece of this whole thing. So let me make that part big. Is that good? Let's just do child hemoglobin and maternal hemoglobin. Okay, so this is maternal hemoglobin before the conception, and this is the child hemoglobin at 3 months. And then they do this unadjusted and adjusted. Let's not worry about adjusted. This is a simple association. This is a regression. So this is a slope. So first of all, if I'm looking at, so I have, what do I have? So I have pre-conceptual, like, so if this is maternal HB, before conception, okay? And then what I'm going to look at is child HB at 3 months. That's what this small number, that's what I'm looking at, this 0.06. That's what I'm going to get at. So first of all, like, what is my hypothesis? Like, what am I interested in here, really? Like, what do I think is going to happen?
Hemoglobin.
Mm-hmm.
When the hemoglobin of mother increase, the child increase for 3 months.
I'm only doing 3 months.
months.
Yeah, let's start 3 months and then we can expand. Yes. So when this one is more, then you think this one is more, or what?
Maybe in the hemoglobin mother increase and the child increase. Hemoglobin for the child increase.
increase. So make this big and then this one will be big. So it will be something like that, right? That's what we think.
When the hemoglobin mother be opposite, more and like a positive.
Positive relationship. So if every dot is one mother-child pair, it might look, if we graph it, it looks like this, right? So your hypothesis is there's gonna be a line like that, right? So the higher the hemoglobin for the mother before conception, the higher you expect the child to be, right? And again, this is not cause and effect, but it's an association, but you think it's positive association. That's your hypothesis, right? So this would be a simple linear regression. And the simple doesn't mean easy. It just means that there's only one variable, which is the mother's hemoglobin. The opposite of simple linear regression is the multivariable, which we will get to. Okay, well, what if maternal hemoglobin has no effect on child? What was it? It'll be the class. Oh, I love it. Okay. So it would be, this is, I call this mom HB, and this is child HB. So it would be something like this, right? Maybe, I don't know, it's messy, but if you tried to draw a line, it would be flat. So even though mom's hemoglobin is getting better and better, the child's hemoglobin is going to vary, but it has no relationship. Right? Even if you increase this a lot, there's no change here. Right? Is this a positive, negative, or zero slope? Positive, right? And this is zero. Okay. So remember that having no relationship is our null hypothesis, right? So let's make it weird, right? Make it weird. Right. We did this thing where I equals beta 0 plus, you remember this from Roger? X plus epsilon. So y is what here in this story? It's a child, yes. So y is an actual number. So it's whatever the hemoglobin is for the child. And then X is mother's hemoglobin, so it's an actual number, grams per deciliter. And then you have intercept, and you have the slope. Yeah? And the slope here, you think this beta, so this is a true number. It's Greek because we don't know what it is. So we make it Greek. And it's going to be some positive number that we want to get. And then here, we think it's 0. So this is no relationship. This is our null hypothesis, right? Our null hypothesis is that the slope is 0. This beta 1 equals 0. It's a flat line. Maternal's hemoglobin does not affect the baby's hemoglobin. And here is what we think is going to happen. It will probably be positive. That's what we think. So Roger writes this stuff. Like, what is this thing? What's that? Tell me some more. Yeah, I think you're saying. Yeah, this special needs. E for, yeah.
What is about that?
About time.
If the how to call, I think from that no, he said that if the hypothesis is 0, it's not.
This is
is equal 0.
no,
Can be, yes.
it's not going to be exact. So this is error, E for error. So E is just this random noise. Like, when you draw a line like this, if you were doing maths class, like you did in secondary school, all the dots are going to be perfect on the line, right? But in reality, like you're going to have, there's going to be some baby that the mother's hemoglobin is low. There's going to be some child who's right here and some child who's right here. Like this is never perfect. This is like this uncertainty. If the world were perfect, every dot is on this line. And this thing is sort of like the difference from here to here. Just by chance, you have a baby who has low hemoglobin. Maybe it's not eating well. Maybe they did, something is happening. Or maybe it's been sick or it has a disease or anything, right? And then you have maybe this child. Even, maybe the mother didn't have a good status, but then she improved her diet later. Maybe they're getting iron supplements or drops or many things can happen, or they eat more meat or something. These things happen, right? So this is the uncertainty. And this uncertainty is just random. This is just natural. People are different. Families are different. There are many other factors that affect a child's hemoglobin besides this, right? So all of those things live here. So maybe this difference is due to socioeconomic status. And socioeconomic status is not here, it's living in here. So everything you're not measuring, everything that is just by chance, all of them is this error term. And it's a nice exercise when you talk to your students to say, what happened, like where does this come from? Some of this can be laboratory, right? Like you take your venous blood to the lab and the reagents, maybe they're fresh, maybe they're old, maybe the one who's doing the lab work is not very careful. But it's a lot of things, right? There's maybe 100 things you can put that creates the uncertainty. So that's that.
Melissa.
Yeah.
At announcements, because you drew the lines to the outliers, but isn't the error term the sum of all of the lines to every dot from the regression line? Like, do you also count?
Yeah. It's not just the outlier. It would be yes.
So just to make it, every single one, so it's every one of those distances from the line.
Right, so this, if the x is, if it's this x, then so if this is the x that you're looking at this mother and child, then you have that x value. This model will give you a y, well, you have your actual y value, right? This is below the line a little bit, but you can find your y. And then you have this little difference, and that'll be here. So that has a little difference and it's negative. This has a little difference, it's positive. This has a big difference, but it's negative. So these are, it looks like Greek, but it looks theoretical, but it's actually real numbers, right? You measure my hemoglobin and I have 10.5. My baby is 11.7. And then you have an intercept and a slope, and you have maybe some error of 0.5 or something like that. Like that is normal. So this is supposed to be like a representation of real numbers. That is your data. So you're going to calculate. You can calculate this. And he did some examples where he looked at residual. So those residuals are those actual numbers. So yeah, good question. Okay, so now we have a hypothesis. And what happens? We have an actual number. So, oops, let me use that. So 0.06. This 0.06 means that I tried to estimate this slope, and I came up with the number 0.06. So my null, so sometimes they put this little hat, they call it beta, and then they put a little hat like that. That means it comes from the data. So I estimated this. My null hypothesis is the slope is flat, that this is equal to 0. Okay, this is almost 0. I mean, it's pretty small, right? It's 0.06.
but it's a little bit more than 0. So maybe the line is not so sharp. Maybe it's like, maybe it's a little bit more like that, little more flat. But is this different? Is this sufficiently bigger than 0? Or is it too close to 0? It is close to 0, but
Not exactly 0.
it's kind of borderline. So with this asterisk, it's saying that it is statistically significant, but it's kind of borderline. So this is the confidence interval, the 95% confidence interval. It's just barely close to 0, but it can be as high as 0.11. It's a small effect. It's a very small effect. It is statistically significant, but it's borderline. The P is like 0.05, right? But because that confidence interval is just touching 0. But and this effect is tiny. What does it actually mean? Like if my hemoglobin is, like what does this number mean, 0.06?
We discussed about a small number, but still positive. Yes, but we saw the significant maybe is a little too different.
There's a difference. Okay, let's do this first. Let's first interpret it and then talk about, do we think this is very important or not important? So I'm just going to say mother, HB. So before conception, right? That's what we're talking about before. Goes up by 1 gram per deciliter. Baby's hemoglobin at 3 months. What happens? Conception and lung. So if the mother's hemoglobin before conception goes up by 1 gram per deciliter, then according to this, the baby's hemoglobin at 3 months does what? Increase. Yeah, goes up or increase. Goes up by 6%. No, it's not a percent. It is 0.06 gram per deciliter, which is very small, but it is statistically significant. So statistical significant doesn't mean that it's very important. It just means it's statistically significant. Right? There's a difference. Like sometimes, I can do a lot of work and I can increase your hemoglobin by 0.06 grams per deciliter. And you say like, well, okay, you spent $1,000 and you improved my hemoglobin by 0.06. Like you could have just given me lunch and I would improve better than that, right? So it may not be practical, right? You may do some study like this where you see an effect and it's statistically significant. You can write a nice paper, you could do a poster, you're very happy, but the actual effect is so small, it's not worth it, right? It might be like, oh, maybe the same money it takes to, do a program that will increase this much, you can use that money to do something better. So, yeah.
How is that considered statistically significant when the confidence interval contains 0?
I think it's like rounding error. That's my guess, is that it's, turns out. Yeah, I don't know if it contains or it's like 0.00. Something like
that. It's right on the edge of significance. I think if we had the p-value, it would be like within rounding error of 0.05. So, okay, now here's another question. Okay, so this is the interpretation. This is the interpretation of the slope. Notice in this, like when we fit a regression line, we do intercept and we do slope. And all we do is talk about the slope. We kind of ignore the intercept most of the time because intercept, the meaning of the intercept is when X is equal to 0, what is Y? Well, X is maternal hemoglobin. If maternal hemoglobin is 0, she's dead and you have bigger problems, right? Like it's impossible. So the intercept doesn't really have a meaning very much here. So we do the estimate. If you did it on Stata or SPSS, you will find an estimate for the intercept. But usually we don't usually pay attention very much. It's the slope we want. Because this is the thing that might change, right? You can try to improve maternal hemoglobin. And if you do, this model that you're predicting will predict how much the baby's hemoglobin will change. And it will increase, but not very much. Yeah.
Sorry, so there may be cases in which the intercept is important because it's where you start. Well, when we see in like a multi-variate model, it could end up being, say you're talking about some kind of score or something, where you start adding additional coefficients. So, yeah.
It depends. Okay, yeah. There are definitely places where the intercept matters, but in hemoglobin,
yes,
probably not, right? Because there will never be data that where the X is going to be, 0 or even 1 or even 2. Like that's just not viable, right? So we're trying to just talk about the area where it's kind of physiologically possible. And again, also you can keep drawing the line up and up, but you're not going to have data up there either, right? Because nobody's going to have a hemoglobin of 30 or something. So it's just within the range of kind of possible values from physiology. So that's the interpretation of the slope. But let's think about this now. So we're interested in child hemoglobin at 3 months at an outcome. And we know that our hypothesis or our research question was about the maternal hemoglobin at conception, right? What else? Maybe, is it okay if I erase this one? No, it's okay? Okay. So this one was very important. I hope you are comfortable. If you're not comfortable, you must ask all the questions, okay? What else affects child hemoglobin besides maternal hemoglobin? Just in general, if a mother brings a baby that's 3 months, like what are the factors in the world that are going to affect that baby's hemoglobin? Can you like some suggestion?
Shy illness.
What's that?
Shy illness.
I can't hear. So.
Shy illness.
Oh yeah. Okay, yeah. So yeah, morbidity. So the child morbidity status. Yeah. What else? Other factors?
Eating habit.
Sorry?
Eating habit.
Yeah. So eating habit, I mean, it's an infant, but child feeding or breastfeeding.
Yes.
Child 3 months. Breastfeeding practice, yeah. Anything else? Kelly has an idea.
Please.
For clamping.
Okay.
Speed of cord clamping.
Uh-huh.
So they don't buy you salad.
Clamping and delivery.
Peter.
Sorry?
Peter.
What?
Peter.
Oh, yeah. Preterm delivery, yeah. Yeah, so there's a lot. I think we can keep going because you guys know anemia very well. Socioeconomic status, maybe maternal education, right? There's a lot of things just in nature. Like this one, okay, you had a hypothesis about this, but some of these can be very, very important. And maybe even more important than this, right? A bigger effect. So that is what this part is. That is the difference between this adjusted and unadjusted. The adjusted is taking into account these other kinds of things. Let me write that. Maternal education, socioeconomic status of the family. Somebody said weight.
It could be lots of things to do with other stuff.
Yeah, other kind of maternal health, kind of, and nutritional status. Could be nutritional status, it could be, there's certain, I mean, anemia is caused not only by, like, it's caused by potentially multiple nutrients. So some of which are delivered through breast milk, some of them are not.
Hygiene.
Hygiene? Yeah, so the hygiene might even relate to this, right? Can affect infection and so on, could be subclinical. So there's a word for this. There's a term for these other factors. What?
Thalassemia.
What? Thalassemia. No, yes. So thalassemia, so genetic things as well. Yeah, so genetics. Okay. But yes, we can keep going. But this whole, all of these factors have a kind of name. What? Independent. They're going to be independent. Because what we can do is put them on this side. Now we can call this X, X1, and have X2 can be genetics, X3 can be morbidity, and keep adding more and more things. But what are these types of variables? What would Dr. K call this? What would an epidemiologist call these?
Exposure or dependent variable, restricted.
Yeah. Those are all actually good. There's another word.
Independent.
What's that?
Independent.
They're independent. Yes, if they are X's, they're independent. They are exposures. Begins with the letter C. Can you spell letter C? Not letter E.
Not the causality, right? Because which one is the intermittent, just associated,
That's right. Yeah, it's not causality.
associated factor. Right?
Yeah, confounder.
Yeah.
Would you call it confounder? Oh,
So some could be confounders. but
Yeah.
some are some effect modifiers, so, you know.
Yeah.
But they're potential confounders, yes.
An effect modifier of maternal hemoglobin before conception. Maybe.
What?
An affected modifier for this.
Well, maybe, I mean, you don't know whether you can call it a confounder or a modifier, so that's another thing. But, yes.
That's fair. But yes, but these would all be things that you can put in the model. So what these are other things that will affect your Y, where Y is the child hemoglobin, right? And all of these things we know matters. And we know, you know this, not because you're just making it up, because it's based on literature, it's based on biology, like it's based on medicine, it's things that you know. It's based on other research that has shown you very clearly, for example, socioeconomic status of maternal hemoglobin, like these kinds of, or maternal education are going to have effects on anemia in general, and probably in this population of children in Vietnam, probably here too, right? So you know this. So what happens is you're looking at hemoglobin, there's a lot of variability here, right? Just natural variation. And some of this epsilon is really coming from maybe these factors, maybe other factors, and you want to sometimes adjust for this. Because if you compare two different children, like, if you can somehow adjust for their socioeconomic status, you can really compare them. Put these in the model. That's what we're trying to do here, and that's what they do. So if you look here, unlock. Let's see if I can make this big. So if you look at this adjusted footnote 3, they adjusted for maternal age, minority status, maternal education, socioeconomic status, infant sex, which is reasonable, child age, which in this case should be 3 months. I'm not sure why that's there. Intervention group. So actually that's reasonable, right? Like, so even though you're looking at kind of an observational situation, from the time before conception, they started doing supplementation after this, right? So some of these children, their mothers were getting supplements and some of them were not. So we want to kind of adjust for that. So intervention group is in that model. Duration of time before conception. So some, became pregnant very quickly. Some of them might have taken 1 year or longer. Early initiation of breastfeeding. So that's part of the feeding practices and IYCF. Exclusive breastfeeding. Oh, sorry, I'm reading the wrong one. Early initiation of breastfeeding, illness and symptoms in the last 2 weeks and 3 months. So looking at child morbidity. So some of those things that you identified, they were also identifying, and they had the data. So they would adjust for all of those things. And what you see here is that, so what can happen sometimes is that this estimate, this slope of 0.06 can change. In this case, it didn't, right? So you have some kind of confidence about this number of 0.06. It's very small, but it is significant. After taking into account all these other factors, you still see a very similar effect. A lot of times this number might change. Sometimes it might go from significant to not significant, and you need to think, what does that mean? Sometimes it was not significant and it became significant. Like, things can happen. We can look at lots of different examples. And notice here, so here, this was 3 months. They adjusted for a certain set of other variables. At 6 months, they adjusted for many similar things, but they changed a few things, right? So, for example, if you go here to 24 months, let's look at this. So at this index, this was looking at a child at 3 months. So at 3 months, they looked at early initiation of breastfeeding. So starting breastfeeding, probably within an hour of birth. In 6 months, they looked at early initiation of breastfeeding, but then now you have a 6-month child. So you can look at exclusive breastfeeding, right? So they added that. And then they looked at illness. In 12 months, now we have early initiation of breastfeeding, exclusive breastfeeding. Now the child is eating complementary food, so they added minimum dietary diversity. So these things that you're adjusting for depend on the outcome. When the outcome is hemoglobin at 3 months, you might have fewer things. As the child gets older, there are other factors like the diet, for example. So as you get older and older, you're seeing more things to control for. This list that you came up with is probably for 3 months. And as you go older, you will add more things, right? So dietary diversity for the 24-month child, or even the 12-month child, you can add dietary diversity, and so on. Does this all make sense?
And it's important to note too that that's specifically because what they want to see as clearly as possible is that association between preconception, maternal and obstetrical hemoglobin, and anemia. Sorry, what's the child, the maternal and child, right? Hemoglobin.
Mm-hmm.
And they want to, I like to think of it as you want to take out all the other noise or reduce anything, when we say confounder, anything that can confound or confuse the relationship between the exposure and the outcome that you want to measure. So this is a really good example of when controlling for 15 things is okay. There are other times when I think that something that happens commonly is people may be building a model, trying to understand a relationship, and they just control for confounders, saying, let's just take all this out, or try to level the playing field. But what they're doing unintentionally is potentially putting things there that could be an important factor in the relationship. But specifically when you're trying to look at this one exposure and outcome, this helps to reduce all that other noise, all the other possible things that could affect that outcome, or that could affect that relationship.
And I would say if you're getting to this type of analysis, this stuff that they're adjusting for, notice that some of the things that they did, you also recommended. But then they did some things that you didn't have, like they didn't have early initiation of, you didn't say early initiation of breastfeeding, but if you thought more, you might have added it. But there's some things you mentioned like hygiene or something that's not here. Maybe they didn't have the data. Maybe they did, but they didn't include, right? These are the sorts of things that people debate, right? There's no right model, right? And so if you do an analysis like this, then you have to be ready to kind of justify, why are you adjusting for these things? And kind of explain, and someone can come to you and say, I don't agree. Like, why did you put breastfeeding? I don't agree. You should remove it. Or they can come and say like, yeah, that's fine, but I need you to add water and sanitation and hygiene. I need you to add, livestock exposure. I need you to whatever, meat consumption or something. Like people, and they will have those debates. And so you have to be ready to kind of justify and feel comfortable about your decision. And there is no right answer. There really isn't any right answer. Yeah. And yeah, other thoughts on this? There are many other things in this, but I kind of want to wait on doing this. Because these are all odds ratios. I'm looking at Kate. We're kind of going to share all of this. These are all odds ratios, and this is sort of a t-test, but it's kind of using indicator idea, and we haven't really talked about that either, but we might want to get to it. I think I should stop here. Any questions on this? We will come back to this when we talk more about odds ratios and so on. Everybody's so cool and happy with the regression now. We'll Do you want to continue with 6.2?
Could do that a little.
Yeah.
It's easier.
What's that?
Computer.
Oh yeah.
Otherwise it would be like.
Yes. Let me download. Wait, I think I did download 6.2. Let me check.
And for tomorrow as well, I would love for each of you to come with some, if you have done your own research, notes for your design, your proposal, it's not to share, to have for yourself. Or if you haven't done your own, an example of research that maybe you've worked on, or a paper that's been published, research that's been published that you're interested in, because we're going to look at them and think about design and bias and a few other things. Again, it's not to share, but it's for you to reference while we're having a conversation. So I just want you to have something available.
So we have
Yes. Absolutely. Yes, so it's okay to bring a paper that you're interested in, research that you're interested in, and just any example. Just like everybody to bring an example with them. They can.
Sure.
We don't have to share it. No. It's just for you to reflect on as we'll have a discussion. You want to talk about ecological fallacy? I know you look excited.
No, I just think that it's such a non-intuitive idea.
Yeah. I used to always have really great examples, but they're all very based on like US sort of humor. And so showing, I wonder if I can find one, but there's one, it's great. It's like number of Keanu Reeves movies released correlated with bus accident fatalities. And if you plot them, it looks like Keanu Reeves might be causing bus accidents. But you can't actually make that conclusion. And that's more of a like correlation doesn't equal causation versus an ecological fallacy. But it's kind of both because it's taking the population level, well, I don't know if we can call it that race. I'm stretching that example. But really, yes, the issue with ecological fallacy being more that people want to take data that they have collected on a population level and try to say that it explains individual level outcomes. So you have to be careful in how you're interpreting your results, particularly if you have an ecological study. Basically, that, yeah, you can say, all you can say is that, child mortality at a country level, say for this, and the prevalence of child wasting at a country level are correlated, but you can't bring that down to the individual. What else in that here? That, yeah. Right, you can't use the group level data. Like it's one thing if you collect data on everyone in this room and we have an exposure and an outcome that we're looking at with everyone in this room and talk about how that affects people in this room. But we can't collect data from all of us, say all of our weight, and we take the average of our weight in this room and correlate that average with, I'm trying to think of a good, we can't say that average applies to all of us. Oh, that's a better way of saying it. So it doesn't mean that we all have that average weight. It's all of us contributed to it. But some people will take the population level prevalence of something like a weight or a risk factor and then say that average, that prevalence on a population level means that we has that risk and NALUPA has that risk and each of you have that risk. Yes, Kelly.
you'll allow me, there's a really,
Please.
an example that's really relevant to this room.
Yes.
Is in Lao, we talk a lot about the risk of formula feeding, right? In the nutrition center, we talk a lot about what is the risk of formula, what is the effect of the health of formula feeding. And when I teach that, I show that it's increased chance of obesity, lower IQ, and many Lao doctors get very mad because their baby is not fat, their baby is not low IQ, even though their baby drank lumen. And I have to explain, yes, I didn't say your baby is low IQ. But the global population data we have shows babies who were breastfed on average have a higher IQ than a baby who was not breastfed. I didn't say that your baby.
Yes, it's not.
It's a real issue in public health because people don't like it. Sometimes they take it to mean that you said me. And so it's something, this is a real issue. Besides research, it's also an issue of advocacy. So that's something just to keep in mind.
I think, I thought the other part of that is that if you look at it at a national level, if you, like a lot of Western countries, the US, for example, has very low breastfeeding rates, but they have some good child outcomes. So if you look at like, you know, stunting if you're comparing the US and other countries, right? They have very high formula feeding, low breastfeeding, but they have very little stunting. And so then you think, okay, well, give formula and then you will reduce stunting. That's not true, right? That is that ecological fallacy.
That's a really good example. So just because a country has low breastfeeding and low stunting doesn't mean
You should stop breastfeeding.
you should.
Oops.
Yeah.
Oops, I went back. Yeah,
It's a
Yes.
really important thing.
We have to buy some gunpowder.
We have to address.
exactly. That's
Exactly.
great. Yes, great thing to pitch in, exactly, because it's not taking into account the multitude of complex reasons that while there may be lower breastfeeding in the US, we may not have the same outcomes. There's so many other things that go into that. Yes, so those confounders, those other cofactors. So that, yes, that's fantastic. Thank you. And right, so additional, bias. Like we said, there's a lack of information on the confounding variables. We don't have any kind of temporality with an ecological correlation. It's a snapshot at the same place in time. Very representative of the population, but we can't generalize it to individual members of the population. It's really just saying, on average, this is what's happening in this area, this population. Okay. So we'll talk a little bit about the surveillance. I'll talk about surveillance prevalence studies and cross-sectional studies together. So hold on, I'm just checking the time in general. All of these types of studies, but particularly surveillance and prevalence, are looking at the health of populations, trends in behavior. So we want to see, what's the pattern of different types of behaviors or risks or disease outcomes, anything that you want to think about. We can use a surveillance or prevalence study. Sometimes this is very classic survey research design, so or a combination of survey and biological measures. So I think the mix data is an example where what's the word?
Multi-stage.
Yes, but there's another it's like sequential. So you're sampling, you're doing the same study in the population every so many years. Thank you, panel.
Yes.
panel study, but you're not sampling the same people. So it's not a follow-up study. It's not a cohort, because in a cohort, you're following the same people for amount of time, right? But in these panel studies, you're taking cross sections of different people in different periods of time. But because we're talking about, these are usually used at a population level, it's okay, because we're not interested in talking about individual risk, right? That's what we'll find in a cohort study. But in these prevalence and surveillance studies, we just want to know where the country, it's like taking the temperature of the country or a region to see what are the issues and how are they changing over time. And really, you want to sample different people so that you get a better over time representation of everyone.
Of the same problem.
Of the same problem, yes. So you keep asking the same, some of the same questions. Of course, you may add or change that as things evolve. There are some really great panel surveys in the United States where we have different modules that are asked in different years. So the same survey may be asked every year or every other year, but there might be different sets of questions that come up, say, every 3 years or 4 years, just so that you can surveil. I want to think that the present tense of surveillance is survey, but apparently it's actually surveil. You'd be able to surveil these things over time. But in all of these, your exposure and disease are assessed at the same time. So cross-sectional, prevalence, surveillance, you're taking I think of it as a snapshot. Do you have Polaroid pictures or like instant photos? Yeah, you're taking a snapshot of the population at one place in time and looking at the exposures and the outcomes all at the same time. Yes, so they're all kind of the same design. Even if they're, sometimes they're analytic, sometimes they're descriptive, but and again, when you're making associations from these types of studies, you are still assessing everything at the same time, so you don't have if you're measuring the exposure and the outcome at the same time, what is a characteristic that you're missing if you wanted to establish causality? The timing, or
The timing, the period of exposure.
the period? Okay, yes. So you don't have any of the temporality. We won't know which came first if we're assessing them at the same time. Okay, so these are often used in, like I said, estimating risk factors or exposures and outcomes in a population, planning and administering healthcare services. So often these will be used by government or hospitals or regions to know how are they going to need to allocate their funding for the next year or 5 years for healthcare. Where do they need to focus? And also for establishing, yes, that preliminary evidence for a causal relationship. So as we mentioned before, descriptive studies, prevalence, surveillance are great for getting the first information you need to then move into a more analytic plan. Yes, and also, so for chronic diseases where we often don't have a lot of information on time of onset, because you have time of diagnosis, right? With a chronic disease, say you have diabetes, cancer, hypertension, it's unlikely that you will ever identify the exact point in time when one individual person suddenly, went from being non-diabetic to diabetic, or not having hypertension to having hypertension. You're only able to capture when you first measured it, right? So we can do these surveillance to kind of capture how that appears in a population over a course of time, so that we have some evidence of what that prevalence is. Okay, so what you...
Sure, I have one question for the surveillance theories. Sometimes the surveillance can be really representative to the whole country, or just to know some area or some region.
Yes, so it can be any of those. It may be that, so for example, the city that I grew up in, they have their own surveillance system for the population of the city, because, in part, because they are the ones with the money and the resources. They are responsible for the people who live in the city. So they want their own surveillance to understand the health issues in the city. And that's great. It could be a city, it could be a region, it can be a country. You can do a surveillance study with any population.
But we can compare to the national survey that there's more samples.
Sure, I mean, you can compare. It's different than, you may not do like a direct, there are ways of doing an analytic comparison, but it's a loose, I guess, would be, Roger and I have discussed this actually, but it's helpful because you may want to know, how does your population differ than the national population? So it's important, I think, to do those comparisons. You just have to find the right method of analysis to do that. And it usually ends up being comparing proportions. So yeah, you may have some insight into how you do. It's not, you don't see it as often in studies, but I think it adds really good information. If you have done a surveillance study or prevalence study in a region, and you add that comparison to a national or different levels of government or geography. So I think I already said this. Yes, you don't follow up with the same people. You take a new sample each time. And I gave those examples. And then you end up dividing, I'm gonna show you this on the next page. So you collect data on as many variables that can be evaluated as cofactors, confounders, modifiers. So many words for things that before you measure them, you can characterize them as a confounder, a cofactor, a modifier, but some of that you may not know till later. But all of the data and information that you think is going to affect your health outcome or your exposures, you should collect as much as possible. And so when you're doing this, you really have to think about power analysis, because if you have many cofactors, you have to account for that in your sample size. The measures of frequency or association that you would use in these studies are prevalence ratios, prevalence odds ratios, regression modeling to include covariates. Some of those words are very epi-focused words, and you might just say odds ratios. You just have to, you'll explain what that you're looking at a prevalence odds versus, we'll talk later about exposure odds. They're different between this kind of study and a case control study or a cohort study. So the last, last thing I'll touch on a little bit is then when you measure the exposure and the outcome, here I just call it disease, exposure and disease or outcome measured. So you have your study population, you're gathering data on the exposure and disease at the same time, all at once, and then you can have 4 possible exposure disease outcome groups. There are people who are, if you have an exposure of interest, exposed, and you have a disease of interest, these are the people who are both exposed and have the disease. These are people who are exposed but don't have the disease. Does exposed make sense? So that's like if maybe a risk factor, say the smoker, maybe, so you're looking at smoking and lung cancer. I know it's the laziest, but the most obvious choice. So smokers who have lung cancer, smokers who do not have lung cancer, non-smokers with lung cancer, non-smokers who do not have lung cancer. So you have 2 exposed and not exposed, diseased and not diseased. And between those, you can make 4 groups. And then you want to look at the association between those. So in this example, their health insurance coverage was an exposure, and whether people are currently breastfeeding their child was the outcome. So you group people by, I do have health insurance and I am breastfeeding my child. I have health insurance, but I'm not breastfeeding. I don't have health insurance, but I'm breastfeeding. I don't have health insurance and I'm not breastfeeding the child. Okay? Any kind of exposure and outcome that you want to measure, you can put into these categories. And then I think we will save and talk about some of this for tomorrow, the measures and how to calculate some of those. Specifically in kind of a prevalence or surveillance study, you're trying to estimate the prevalence of an outcome or a risk factor. And that's the cases out of the total population. And we talked about that, like point prevalence or period prevalence, which you have in surveillance. So point is when you're measuring it at one point in time, like Nilipa was saying that birth just happens once. It's one point in time. But maybe something that could occur during pregnancy could occur at any time during the pregnancy. You would need a period prevalence, the period of pregnancy, and then you would measure when it occurs during that pregnancy, if that makes sense. Or as we mentioned, like the chronic disease, usually you look at a period of time and how many new cases of the disease happened in this period of time.
Is that the same as incidence?
Yes, but incidence, you have person time, so time is a factor of the study design.
This is like just time. This just within 1 year.
This is calendar time.
You have this many births.
Right, because it's the denominator. So the denominator is your the total population, right? But usually, but they often are equal. I actually took out an entire lecture on incidence and prevalence, but I can touch on it tomorrow because I think it's an important question to understand.
What I remember about incidence, the total events and for total events with total person observed.
Yeah, like it.
Counting event, rather counting the occurrence of the disease, but counting event. The event is not the.
Yes, it's like an event rather than just counting a case.
It's usually about something happened or has been like a quick happen of disease.
Yes, like everybody getting sick on a cruise ship. There's Yeah, you know what, I'll bring a slide and talk a little about incidence and prevalence tomorrow, because I think it's a good thing to cover.
I think many people, to me as well, sometimes I remember, but I'm not so sure really, which I should look at the prevalence wise of disease and everything.
Yes, we measure incidence far less than it seems, because it really is kind of shaped by this idea of time in a way that's different than how we normally do studies. So it's reserved for more, sort of time-bound outbreaks are a great example, and some other things. But yes, I'll talk about that. It's always like trying to have this like an epi leaning, but without getting too much epi that nobody really cares about that much.
Great if you could provide some examples about period prevalence of what kind of disease that we look at period prevalence rather than by time occurrence.
Right, yes. Okay, I'll do that. And I think the easiest explanation really is that, say, you're doing this measure a year apart, and your period prevalence is going to be the number of new cases over the past year, right? The point prevalence would be the number of cases in that like exact point in time. Yeah. But I will bring examples to make that easier to understand. Yeah. Right. Okay. I have a little bit of, because I have an example right here. Didn't even realize. Right. So here's an example. The proportion of children seen in a clinic who have stunting. So point prevalence, 12 out of 48 children seen on June 30th. So the prevalence is 0.25, or 25% of children have stunting. Period prevalence is this 1,836 have stunting out of 8,000 children seen in the clinic over the past year. So that prevalence is 23% of children seen in the clinic over 1 year have stunting. So it's more about the period of time over which you're counting cases. But I'll bring more examples tomorrow. So we'll talk.
Oh, can I ask
Talk
another
more?
question?
Sure.
So there are some things, like stunting, there's usually, like catch-up growth is very tricky. But if they were like something where you have something and you recover, like hospitalization, or like a case of influenza,
Yes.
something like that,
Yes.
then would you use period prevalence?
That's such a good question. I'm gonna bring my cut slides.
Okay.
Because it's an important question, because of how people are counted. So, I'm not gonna be able to answer that in a quick couple of minutes.
Okay.
So I'll bring an example tomorrow.
You will answer by 8 a.m. tomorrow.
Yes, absolutely, I will. Are there, and other people are interested in this idea too, kind of understanding between incidence and prevalence and how we're measuring this? I know I'm getting some faces of.
Some people are not sure, some people are sure.
Okay, I'll bring it, and if there is only some
We could do
interest,
after school.
yeah, I could do an after school session tomorrow if needed.
Konsumsi kebanyakan berkat. Konsumsi sekolah anak itu konsumsi nasional ini.
But it,
Pagi range so incidence berkat. Berkat anak kita itu main. Atau jumlah sang punในส่วนที่สังเกตส่วนkonsum nanti juga dengan dengan mentor pasaport ya pasaport nasional class. Kanya ganit ako dito. I made it more.
Thank you. You made it what?
I made it more.
Okay, good. Excellent.
You raised up recently about Hillary and bus accidents. I'm not very sure that they watch American movies and
Yes, well, exactly. Which is why I didn't have my candidates slides. Okay, well, I think that we can kind of wrap this up for today. And any burning questions before we do that? And please know that if you do have questions, you're welcome to come and ask us. You're welcome to bring them, bring them in the morning, bring them to us after school or anytime. We're happy to help.
I have a question. Is anyone interested in applying to PhD programs in the US?
Is anybody having a plan?
Interested in applying to PhD programs in the US? Yes.
What's another
Fellowship, something or anything.
I'm just asking because I could do that. We could just have a discussion, an after school discussion, meaning after 3 o'clock for one of these days.
It's not only PhD, but maybe so-called training, like 3 months, 6 months for data analysis, health policy.
Visiting scholar or other.
Or choice.
Right.
Program for her students, free hands. Sorry.
Expect but worry about
We have a question.
There's a question here. That this topic is very interesting. When people here want to apply for yes, yeah, I already yeah, it would be so I just want to know that when you make discussion about it yeah, the treat or the yeah, all these
It seems like maybe you should be during
I mean, we can, yeah,
I think they do have this.
or at lunch.
Or is that too much? It's too much.
Okay. Oh, yeah, we can find it. You think it should be between 9 and 3? One of these days. We can do it. We can keep it 3.
I'm really gonna, like, just to make sure. Do some of you have, things that you need to go and do after 3 p.m. also?
You're saying, are you not available after 3?
maybe because there's more cold.
Not 8 p.m. 3 to 4.
Yeah.
Sorry. Yes. Well,
Well,
yeah, Kelly, we're trying to determine whether this
Okay.
should,
They're saying it's not custom.
yes,
Still, people have other requirements, so they don't have to get out just to three.
okay.
okay, so 4 is okay, up to 4.
So maybe, yeah. Tomorrow, the next day. So she wanted to know when. Do you think tomorrow or the next day or maybe a few days?
Let's say Wednesday. I don't know, I'm making up days.
So probably Wednesday after?
Wednesday, 3 p.m.
At 3?
Yeah. On Wednesday.
Is this okay?
That way you can plan.
Okay.
But I should say, like, so it's not for, of course, if you already have PhD, like, I don't think you need 2 PhD, but also, like, I only really have expertise in the US system. I think the Canada may be a little bit similar, but the Europe is very different. So I don't know how translative, I don't know about the external validity of, for Europe. So just to inform, yeah, it's really the American system that I'm familiar with.
And maybe if, maybe I can try to look into some visiting scholars and for people who already have PhDs and.
Yeah, he's just gonna talk about how to write a statement.
Yeah, yeah. All right.
Okay, Wednesday at 3.
Well.
I mean, it's optional, guys. It's so if you're not interested and you have something to do, then you don't have to come at 3, but you can leave at 3 o'clock. It's okay.
You receive each and three.
Yeah, interesting.
Yeah, yes, okay.
Okay.
You know, like, me and
I
Harry
need
got
to feel
wasted.
That's right. Okay. All